Good morning. I'd like to welcome everybody to the March meeting of the ICD-10 Coordination and Maintenance Committee meeting. I'm Pat Brooks. I'm the co-chair for the procedure part of the meeting, and I'd like to introduce our other two CMS staff that will be presenting today. One is Maddie Hugh, is sitting down front, and Michelle Joshua, who's back in the back, she's waving at you, will be also presenting. And later today, at the end of our part of the meeting, we'll have Rhonda Butler for 3M, who will be going through some addenda items. If you'll turn to page 8 of your handouts, we'll go through the introductions and overviews part of the slides. As you'll see, the ICD-10 Coordination and Maintenance Committee is a public forum where we discuss updates to ICD-10 CM and ICD-10 PCS. This meeting is simply to give you an opportunity to learn about requests we've received to update ICD-10 and to give the public the opportunity to comment either for the proposal, against it, or to offer alternative suggestions. The meeting will be co-chaired by me for the procedure part and Donna Pickett, who's sitting on the front row. At the conclusion of our part of the meeting, Donna with CDC will come over and start the diagnosis part. Perhaps late this afternoon. If we don't finish by 5, then she'll be starting tomorrow morning. We have coding proposals to give you the opportunity to think about what's asked for. Some of them have multiple options. And then we give you the chance to comment. You can do that either today in the auditorium or on the phone or later in writing. And you see that the code proposals that we're talking about today for ICD-10 PCS are under consideration for implementation on October 1st, 2017. Now that's assuming there is support for it and there are no unresolved issues, then we would implement those October 1st, 2017. We will not make any final decisions at the meeting today. I frequently get that afterwards. People say, well, I heard those comments, what's your decision? We won't make any decisions at the meeting today. We will just go through all the options and let you ask questions and send comments. And you'll see on the paper that we want written comments. You may make a comment at the meeting and some of you will think about it a little further and maybe change or magnify your comments. That's good. Put those comments in writing by April the 7th. It's a fairly quick turnaround. We need them by April the 7th for any codes discussed today. And you'll see in our handout on page 8 that we have an address we want you to send your comments to, ICD-10 Procedure Code Request at cms.hhs.gov. And separately, when Donna leads through her part of the diagnosis, you'll be sending your diagnosis comment to Donna Pickett at nchs@cdc.gov. Now, people ask, when can I learn about the approved codes? Well, one of the earliest ways you'll learn is in April 2017, thereabout. We will have the Inpatient Prospective Payment System proposed rule. And part of that rule will include something called Tables 6. Many of you are familiar with Table 6. It includes new, revised, and deleted codes. That will include all the codes that are going to be implemented October 1st, 2017 that were discussed at prior meetings. In other words, September 2016 Coordination and Maintenance Committee meeting where we had proposals and we got comments. Any that are approved by then will be in that proposed rule. The codes discussed today will not be in that proposed rule. They don't have time to get comments and cleared. So in August 2017, when you see the Inpatient Prospective Payment System final rule, you'll see the Table 6s again, and that will include all final codes, new, revised, and deleted codes. Now, the detailed addendum, when you can learn about what codes are approved, will be on posted on the CMS and CDC website in June 2017. That will include a complete list of addenda, the complete coding system like the electronic code books, the guidelines, and it will also include a very important tool, the conversion table. This talks about for every new code created, for instance, if there's a new PCS code created, we will say the year it came out in one column, and we'll say what the prior code was. So that's a very valuable tool. And you'll see the addendum where we will post these in June on the bottom of page 8. There's the CMS website, which has the ICD-10 PCS, and we'll also, as a courtesy, probably put the ICD-10 CM codes. But you can look to CDC's website to find their updates for their final decision on the diagnosis code. Turning to page 9, the general equivalent mappings. We'll be posting the fiscal year 2018 general equivalent mappings by August. And as you know, we developed these to help people who are getting ready to convert their systems for the implementation of ICD-10. Well, we've implemented, and we've been doing this for a while. So this 2018 GIMS will be the last GIMS update. So you can look for that last one, and those of you who still use it for whatever reason can use it. But most of you are going to be using the conversion tables. When we create new codes, you'll look at the predecessor code, and those predecessor codes are now ICD-10 codes. Our next meeting of the Coordination and Maintenance Committee meeting is September the 12th through the 13th. And so you have until July the 14th to submit a request for a code to be included on that topic. And once again, send the procedure codes to the CMS request address, diagnosis code to the diagnosis request. So as you see, people are participating in this meeting 3 ways. We have a nice crowd here in the auditorium this morning. We also have people that are using our free conference lines. And then we have additional people that are watching live stream at the meeting. For those who weren't able to do any of those, or you may tell your friends that after the meeting, very shortly, within a few days, we will be posting the live stream so people who couldn't participate today can watch what happened. And we hope this gives more people an opportunity to learn about code updates. Once again, please send your written comments by April the 7th. Sometimes Donna and I get comments in October or December, and they're very surprised to hear it's too late. The decisions were made and implemented on October 1st, so please do notice that April the 7th is a firm deadline. And once again, the most frequent question I get after the meeting is, when will these be implemented? Today's codes are for consideration October 1st, 2017. Now we have a little news item I put on the bottom of page 9 to let you know. Prior to now, if you wanted a copy of the Grouper or MCE, Medicare Code Editor software, you had to go to NTIS, was the government body that sold that software. Well, they have now decided not to do so. So what CMS is doing is we are posting the software on our website so you can download that for free. So those of you who haven't seen it, Maddie went through great links working with our provider billing group to have this posted. It was not an easy thing. And it's now available to people to use on the website given at the bottom of page 9. I will now introduce our first speaker, CMS Speaker of the Day, Michelle Joshua, who will introduce the first topic.
Good morning and welcome again. I am Michelle Joshua, nurse consultant here at CMS, and our first topic for today is cerebral embolic protection during transcatheter aortic valve replacement. This morning's speaker and presenter will be Dr. Alexandra Lansky from the Yale School of Medicine. Dr. Lansky.
Thank you very much, and it's my pleasure to be here. So I'm going to give you a quick overview of a new procedure and why it's so important. I'm a cardiologist at Yale University. I head up the clinical research program for cardiology at Yale. So TAVR procedures, for those of you who do not know, this is a minimally invasive procedure that is an alternative for surgical valve replacement in patients with severe aortic stenosis. Since 2002, this has been approved in extreme risk, high risk, and intermediate risk patients, and we've seen a growing number of such procedures being done on a global level. About 250,000 patients being done globally, and quickly increasing to about 300,000 patients on an annual basis. What we're here to talk about is one of the complications that we see following TAVR as well as surgical AVR, and that is cerebral emboli to the brain. We've seen this in the vast majority of patients. We know this from imaging, sensitive imaging using diffusion-weighted MRI of the brain, as well as a recent study that has looked at capture of debris during the procedure, again, in virtually all patients. What we know as well is that stroke tends to be underreported in the clinical trials that we have seen. The large randomized trials looking at TAVR and surgical AVR have used the Valve Academic Research Consortium definitions of stroke, which tend to be an extreme of stroke. So strokes are reported in up to 6 or 7% of cases. If we now use the American Stroke Association definition of stroke, that uses imaging as well as a neurologist to go and evaluate these patients, you can see that the stroke rates are really in the range of 15% and above, so much higher. Consequences of stroke, we know for our patients, are devastating. We know that there's about a 3-fold increase in mortality in these patients. Physical functioning is significantly impaired. About 40% of ischemic strokes lead to moderate to severe impairment and disability. And we also know that in a working population, this has also devastating effects, and only about 44% of patients are actually able to return to work. 33%, or a third, claim significant financial strains, and the vast majority, about 80% of patients, claim social isolation. So again, devastating consequences of these events. Coming back to the imaging of the brain, when we do these systematically after TAVR procedure and surgical AVR, you can see that the vast majority, close to 100% of patients, have documented ischemic brain lesions. We know from the literature that this is actually linked with long-term cognitive decline. It is associated with a 2-fold increase in dementia and is a marker for subsequent stroke, so 3-fold increase in the risk of subsequent stroke. The US NeuroTAVR study was a registry that we performed in the United States really to validate what had been done in other parts of the world. And what we wanted to understand in patients that were did not have any protection, what actually was the stroke rate if we were to use the American Stroke Association definition. And certainly we confirmed that the stroke rates are actually very high. Post-procedure, we saw a 23% stroke rate and 15% stroke rate at 30 days. So again, confirming what has been shown in other parts of the world. What does this translate into in terms of cell death? On average, we're seeing an ischemic burden to the brain of about 300 cubic millimeters. And what this translates into is about 20 million neurons and 1 billion synapses being wiped out. So if we do have the opportunity to prevent these, then I think it is in the best interest of our patients. What we know from prior studies is that if you look at the overall stroke rate at 30 days, over 50% are happening right there during the peri-procedural time frame. So it is procedure related. 40-some% happen post-procedure to 30 days. Why is this? Well, if you take a look at these valves, these calcific degenerated valves, I think it's no surprise as you imagine implementation, wiring, and placement of the valves, that this would lead to embolization. 20% of the blood flow goes to the brain, so you can understand how this happens and how we see such a highly prevalent rate of embolization. Just a quick lesson here in terms of anatomy. So what you can see is that the aortic arch gives 3 cerebral vessels: the innominate, the left carotid, and the left subclavian that gives off the left vertebral artery. What we know is that it's very important to cover all 3 cerebral vessels. Why? Because there's an equal opportunity for these cerebral emboli to go up and affect all 3 territories. And we know this from previous clinical studies looking at this. So very important to cover all 3 vessels. I'm going to talk about 2 devices. The Sentinel Cerebral Protection System that just went to panel, FDA panel just a couple of weeks ago, is a capture device. You can see that there are 2 filters. They sit in the innominate and the left cerebral, the left carotid, I'm sorry. The left vertebral is left unprotected. So it really covers and protects 2 of the 3 vessels, and it actually captures debris. It's delivered through a third access, so we need a third access for this device, and it's delivered through a right transradial sheath. The TriGuard device, which is the device that we want to talk about today, is different. As you can see, it's a shield. It's made of nitinol, and it's a deflection device, so it's not designed to capture debris. The other important difference is that it covers all 3 cerebral vessels, not 2, but 3 of the cerebral vessels. You can see that it sits on the roof of the aortic arch. It's held in position by a stabilizer and allows us to do the TAVR procedure, deflecting any embolization downstream and protecting the brain. How does this work? The access is through the contralateral femoral artery that we need to get anyway. We put a pigtail through that contralateral access, take a picture. Then through that sheath, we put a 9 French sheath through that 9 French sheath, a 7 French sheath that holds the TriGuard. And as you pull these back, the TriGuard device deploys and goes into position, and once again is kept in position through the stabilizer in the innominate. So just to go through some data very quickly, the DEFLECT 3 clinical study was a study that we did in Europe to benchmark clinical events. This is a relatively new field, and it was very important for us to understand the clinical events associated with these procedures and what benefit we can anticipate. We randomized 83 patients, 1-to-1, followed the patients in hospital, did diffusion-weighted MRI of the brain following the procedure, followed these patients out to 30 days. You can see the deployment success was 94%. Successful positioning for the duration of the procedure was 87%. This is important. When we looked at the diffusion-weighted MRI, we saw complete freedom from any ischemic lesions to the brain in about a quarter of the patients. This is both by intent to treat analysis, looking at all patients, as well as per treatment, those patients that prospectively had been identified by an independent core laboratory to have complete protection. So a quarter of the patients have complete freedom of any ischemic brain lesions. In terms of the clinical outcomes, again, this is a benchmarking study. It's not powered to detect significant differences, but based on the American Stroke Association definition here, you can see that there is a significant or large numeric difference, 12% versus 2% based on ITT, and a 12 to 0% based on per treatment. So if we have complete coverage, we're really eliminating any kind of stroke. On the right panel, you can see the differences, numeric differences in cognitive measures favoring the TriGuard device. I'm going to show you next our pooled analysis. What we've done here is, because we've done 3 trials now with identical protocols, methodology, core laboratories, and definitions, we have pooled these 3 studies. They include our CE mark study, that was Deflect 1, Deflect 3, and NeuroTAVR, 142 patients, 59 of which received TriGuard and protection. I'm going to show you the MACE, the safety endpoint at 30 days, which was defined by all death, stroke, bleeding, acute kidney injury, and vascular complications, and then a whole host of different efficacy metrics. So here it is. The primary safety endpoint shows that this device is safe. At 30 days, MACE was 18% with TriGuard, 24% in the controls, no significant difference. If you look at the efficacy metrics of stroke, VARC2 stroke, again, which is an extreme of stroke, was actually significantly reduced in this pooled analysis, 6% versus 0. Looking at the American Stroke Association definition of stroke, it was 19% versus 0. And again, if you look on the extreme right, we confirmed in this pooled analysis that more than a quarter of the patients actually have complete freedom from any ischemic brain lesions. So to conclude, first, stroke and neurocognitive decline are significant complications of TAVR. I think we've shown this time and time again. TriGuard during TAVR is safe and provided complete cerebral coverage in 87% of cases. Complete cerebral protection with this device reduced stroke risk, unintended cerebral injury, and measures of cognition. And because we believe that this device actually has a different mechanism, covers all 3 vessels, and may offer some benefits to our patients, we believe that modification with a greater granularity of the current procedural codes is actually needed to support the accurate reporting and outcome tracking for our patients. Thank you. Any questions?
Moderator, will you open the line for questions?
All lines are now unmuted. You may ask your questions if you have any at this time.
It's still in trial. It's coming out of trial.
Something like that.
Are there questions on the line? The line is open for questions. Okay. Noting that there are no questions, we thank you, Dr. Lansky, for your presentation. We do have a question. Wonderful. Linda.
Sorry, it's delayed reaction. Can you speak again to your assertion that stroke following TAVR is underreported? I didn't quite catch why you felt that was the case. I understand there's somewhat different definitions, but presumably you were looking at academic studies or something like that. I'm questioning it because when I'm reviewing a medical record, I don't really have any trouble identifying if a physician says, patient had stroke following TAVR. So,
right, so the definition of stroke really depends on how sensitive your approach is. Most of the randomized clinical trials have really sort of defined stroke based on clinical symptoms. So you have to identify the symptom to be able to define the stroke. The symptom will then drive imaging, which will confirm the stroke. The American Stroke Association takes a very different approach. They depend far greater on imaging. So, and also, if you have a neurologist evaluating the patient, they have a much more systematic approach to evaluating that patient and detecting symptoms. And that will trigger, more imaging, et cetera. So having a neurologist and imaging will increase your sensitivity of detecting stroke. So it's just a difference in the approach. and also in the reliance on imaging. And that is what leads to this difference that we've detected in stroke rates.
So on a practical basis, then, someone who receives a TAVR is not routinely evaluated by a neurologist afterwards?
Clinically, no. Clinically, no. And in the early randomized clinical trials, the symptoms of stroke were not, a neurologist was not required to go in and to evaluate the patient. That has been implemented, more recently.
Okay. So on a routine basis, if someone receives a TAVR, then the primary or attending physician would be looking for symptoms and would only call in a neurologist if symptoms were identified. Otherwise, there might not be a neurologist involved.
Exactly.
Okay,
exactly.
Thank you very much.
Yep.
I guess another delayed reaction. We must not have had enough coffee this morning.
Nellie, say your name.
Oh, sorry. Nellie Leon, she's saying American Hospital Association. Question, this technology, do you ever foresee it being used in another procedure, another part of the body? And as a follow-up to that, it's intended to be a temporary device that is used while you're doing the surgery, correct?
Exactly. So it's placed before the TAVR procedure, removed at the end of the TAVR procedure. Absolutely. So it's a temporary device. I think number one, we need to, in terms of other areas of the body, I think the first and most important, obviously, is the brain. I think this is something that we're getting greater and greater awareness. I think the evidence now is here for its use in that context. I think it can certainly apply to other cardiovascular procedures. We're well aware that stroke and cerebral embolization is associated not just with TAVR and surgical AVR, but other cardiac procedures. I think in terms of protecting other organs, I think that's open to debate at the moment. I mean, potentially you can envision protecting the kidneys and other parts of the body. I can say that with a deflection device, with this device, we have not seen any increase in systemic embolization or other complications from deflecting debris downstream. You have to understand that about 20% of blood flow and emboli go to the brain out of the entire, cardiac output. And, the distinction between a capture and a deflection device, I think, is very important. But again, I think it's important to stress that we have not seen any complications from systemic embolization.
Okay, thank you. I'll have follow-up questions once we get into the coding piece.
Sure.
Just, by the way, I didn't introduce myself before. I'm Linda Holtzman from Clarity Coding. Just to Nellie's point about use of cerebral embolic protection or embolic protection and other procedures, it is currently being used in carotid artery stenting, correct?
That's exactly right.
Right, because
yes.
I do see it there routinely. I believe it's required for
That's exactly right.
the C word.
Different devices, but that's absolutely correct.
Okay, so cerebral embolic protection itself is not a new technology. It's a new usage here after TAVR.
Right,
That's,
in the context of TAVR.
Thank you.
Yes.
And thank you for your patience.
Hi, Laurie Johnson, Panacea Healthcare Solutions. I just wanted to be clear that this is a device that remains after the procedure, or is it pulled out at the end?
Yeah, the device is placed before the procedure, so it's the first thing that goes in, and it's removed at the end of the TAVR procedure.
Okay.
So the TAVR procedure is completed, then the TAVR system is removed, and then as a last step, you'll remove the protection device.
Okay,
Yeah.
thank you.
Yeah.
Do we have any additional questions at this time? Okay. Thank you, Dr. Lansky. If you're following along in your agenda, we will proceed to the coding options, which start on page 11. Current coding, there is no unique ICD-10 PCS code for cerebral embolic protection of the innominate left common carotid and left subclavian arteries used during TAVR procedures. Current coding code the TAVR procedure only with the appropriate values from Table 02R, replacement of heart and great vessels. Coding options include: Option 1, do not create new codes for cerebral embolic protection during transcatheter aortic valve replacement. Continue to code the procedure using the current coding as described. Option 2, create a new code in the Section X, New Technology, to identify a frame deployed in the aortic valve to cover the innominate, left common carotid, and left subclavian arteries and deflect debris that may be dislodged during a transaortic valve replacement procedure. I might add here at this time that the requester plans to apply for new technology add-on payment for fiscal year 2019, right? A separate code for the valve replacement procedure would also be reported with this option. And you'll see that option on your screen for table X2A. CMS's recommendation would be option 2, to create a new code in Section X, New Technology, to identify cerebral embolic protection of innominate, left common carotid, and left subclavian arteries used during the TAVR procedure. Interim coding advice would be to continue to code the transaortic valve replacement TAVR procedure only. Do we have questions regarding the coding options?
Nellie Leon, Chisane American Hospital Association. I'm having a little trouble with the root operation assistance. Not that I have a better one other than insertion, but it's a device, and right now the guidelines do not allow coding of devices that are not left behind. But I'm struggling with a filtration device being something that takes over a portion of a physiological function. Because it's not like we already have a filtration function within these vessels. So I was wondering if you could speak to the root operation assistance, why that was picked.
Okay, I thought you were going to say something. Okay, we note your comment, and we thank you for your comments at this time.
Okay, so no explanation right now. Okay.
No.
And second, I think that based on the current guidelines and the instructions about not coding devices that are not left behind, I know that at the previous Coordination and Maintenance Committee meeting, there was a proposal where there was a qualifier for a device where the word temporary was added. So that it would be clear that it was a temporary device, and I don't know what the plans are for the PCS guidelines, but would you consider adding as part of this description here for the device perhaps temporary, because someone doesn't understand the technology, doesn't understand why this was created? It could give the impression that you're leaving behind a filter.
Yes, we would certainly consider adding temporary as a qualifier.
Thank you.
Thank you. Are there additional questions on the line? On the telephone line? Okay.
This is Sue Bowman. Can you hear me?
Yes, we can hear you, Sue.
I just wanted to concur with Nellie's comment about considering having the qualifier temporary. And I also share her concerns about assistance. When you read the definition of it, doesn't seem to really describe what this particular device is doing. However, I'm not proposing that we should consider insertion or removal, because we do have the guideline about devices that are not left in at the end of the procedure, not being coded. And I think that's an important guideline, because if we didn't have it anymore, then we would perhaps be in a situation where it might be difficult to distinguish between devices that a patient is walking around with in their body versus sort of intraoperative equipment that is just used during the surgery to accomplish the procedure or prevent complications. So just some additional thoughts for consideration. I'm not sure exactly what the best approach for this is.
Thank you. Do we have additional questions on the telephone line? Okay, we have a question. Yes, proceed. Okay, we have a question in the audience.
It's more of a comment, which I haven't completely thought through yet, so that's always dangerous. But I wonder if we'd be better off trying to develop some kind of more generic code for the use of cerebral embolic protection or embolic protection anywhere, which could then be added to the primary code for the primary procedure. So that's my first point, as opposed to itemizing every type of protection device. And I do understand that the applicant is looking for a new technology add-on, and that there has to be some way to uniquely identify it. And this is typically how we would do it. But I wonder if perhaps the request is a little premature, since they're looking for an add-on for fiscal year 2019. Maybe we should, take a bit of time and think through some of these other issues and perhaps consider it for next year. Just a thought.
Thank you. Okay. Are there any additional questions either on the line or in the audience? Noting that there are no additional questions, we will move on to our second topic. Thank you.
If you'll turn to page 12 of your handouts, we will now go through the oxidized zirconium polyethylene implant for hip and knee replacement. And the issue is that there is not a unique code for oxidized zirconium on polyethylene implants for total joint replacements. This is a repeat topic, and our requester has made modified requests for the codes. It is not a request for new technology, and yes, it has been FDA approved. So now I will introduce our clinical presenter. Dr. Mark Snyder, the medical director for an orthopedic center of excellence, will now describe this technology.
Well, thank you for the introduction. It's nice to be here with you. As I came in this morning and had the rain pelt down on top of me, I imagined that every raindrop was an acronym. And on the basis of that, I knew I was in the right place. To be fair, however, as I return home to Cincinnati later today, I'll be rained on in exactly the same way. So I would like to discuss with you just a little bit the clinical aspects of this technology that is FDA approved and already used in thousands and hundreds of thousands of patients. I disclose to you, this is the standard American Academy of Orthopedic Surgeon disclosure thing, which has to be updated every 3 months. This is the current one. I receive no royalties for this material, by the way. Now, from my personal experience, and I want to talk about what that means, orthopedics is different from cardiology and cancer because registry tracking and outcomes embedding in care pathways is actually kind of a newcomer to orthopedics, sadly. We can't possibly find ourselves equivalent to the cardiovascular world or the cancer world, but there have been some major pushes, and we have one of the earliest pushes to do this, and it's from this experience that I'm speaking. I'm fellowship trained in total joints, which means clinically that I took an extra year in Boston to learn new procedures and to consider new research methods for total joint replacement. It is significant, being arguably the highest Medicare spend in terms of relevance. So I had an interest in this for years. I do have a lot of years, and I look older, and I do have 5 more years of clinical practice in my hopes. But lower extremity arthroplasty has been what I've cared about the most because I was drawn to it, seeing how tremendous the improvement was in a patient's life immediately after surgery which actually changed everything in musculoskeletal care. Now, I first used this 17 years ago. It was actually in a knee replacement patient, so I have a large experience with it. Now, when I talk about no revisions and no this or no that, this is an important thing I want to point out. Total joint replacement has been the subject of international registries for many years. The registries that were first developed were developed in Scandinavia and England. And these registries were basically designed to detect what the rate of reoperation would be for implant-related problems in patients associated with their name and their diagnosis, and quite frankly, very little more. When I talk about a registry, I'm talking about a level 3 registry. And a level 3 registry is a registry that detects not only the clinical diagnosis and the implant type and the patient identifier, but also their risk structure and their patient-reported outcomes, as well as their complications. So when I talk about experience, it's not a casual thing, it's actually a lifelong passion to do something that was never done before. And we actually have a 6-year level 3 registry tracking tool, which is not the subject of this appeal, but to give you an understanding about my clinical background, so that when I say that there were no revisions for prosthetic wear related to this implant, it is on the basis of that kind of registry tracking. Again, the detail of that was not the subject of this request, but I want to tell you that the reason that the code could matter for me clinically, for me as a clinician, is that if I had not done the tracking of the name of the implant and the type of material that it was, I would never know what outcomes were related to that device, to that implant. But in fact, I did without the help of ICD-10 coding. Not that I'm faulting it, I just didn't have it. But on the basis of our registry tracking, we were able to identify which implants were actually of this type, and then we could then later on decide if this is something that we wanted to use in a patient who had 20, 30, or 40 years of implant exposure left in their life. That's why it's clinically relevant to me as a clinician. When I use the word osteolysis, I'm talking about the damage to bone that occurs after an implant is put in, and if it wears out, it actually can damage the bone by releasing small particles, and certain patients have biologic tendencies to overreact to it, sometimes erasing the supporting structure for the implant in the entire pelvis or knee. And this is a well-known complication related to the type of material that's used. We also found that we had no revisions in these almost 4,000 cases for a feature called trunnionisis, and I apologize again for a term that's not common to you. I listened to the TARV lecture, so I think it's fair game to use a term that should be explained as well. Trunnionisis describes what happens to an implant when the ball rests on the prosthetic neck or stem and actually can wobble and move in such a way that it causes metal debris to be released, which also can damage the skeleton. And we found no cases of this occurring, no revisions where we found this finding at the time of surgery. So it is an important thing to understand that this personal experience is registry-based. I love codes, I love registries, and America is far behind but trying to catch up rapidly in orthopedics. Now, there is a difference between this material called oxidized zirconium and regular ceramics, and quite frankly, if we are able to track this, both researchers and clinicians that are using registries will be able to look back and see that there might be a difference with one material versus another. This is not a ceramic. You know, one of the coding representations currently is to say that no matter what the ball material is of the total hip, for example, all ceramics are ceramics no matter what they are. But in fact, this is entirely fundamentally different. This is actually a metal material where the surface is transformed into a ceramic-like material. It's not a coating. It will not rub off or flake off. And this is important because For me, clinically, as I look back over the years, you have to understand again how old I am. When I first started total joint replacement 35 years ago, we had terrible implants that failed often. And one of the breakthroughs that we were looking forward to was material that would actually change the game and not wear out and not cause early revisions or late revisions in patients. So when I look at a material and I think of a ceramic versus a special type of metal, which this is, I know the difference. I've revised the ceramic failures. I've looked at this issue very carefully, both in the research and in the clinical experience. And so we believe it is important to identify this as an entirely different material, even though FDA approved and already used. Now this slide is a registry report from Australia, I believe, or New Zealand. I can't see it well. The print's too small for me, and I apologize. But what I want you to look at on the curves here is that the bottom line, the bottom purple, actually represents, over a more than 10-year experience, the difference in the reoperation rates for implant failure, looking at different materials. And what we have here in a greater than 10 years tracking with hazard ratios to let us detect even higher rates of revision at earlier stages is that this material is associated with a decidedly lower reoperation rate in a long-term registry tracking experience where, in fact, the registry knew, if you will, to anthropomorphize it a little bit, what material it was. Looking back, what was used, what now can be tracked to determine if there's a better rate of longevity and a higher rate of reoperation. Now, the registries that are tracking this as if they had an ICD-10 code, of course they don't, they have different kinds of coding structures, but there are many registries around the world that are doing this, even some registries in the US that are saying we do believe that there's a need to be able to track something better in the long term, and it would be better if everyone was tracked in this way, not just those that are in our state or in our country. And we know that outcomes have been looked at clinically very extensively, and these are some of the publications that talk about that. And you know, certainly well over 1 million have been implanted since it was available. Now, this is something that I want to tell you about from clinical experience. I'm not going to pontificate about metal allergy and what the research shows, but I will talk to you as a clinician who takes care of people. And that is that we know that many people have problems after total joint replacement. We know that knees in particular seem to be susceptible to high dissatisfaction rates in up to 20% of patients. Part of this can be explained, possibly, on the basis of metals that are used in the implantation. We know that there are higher nickel contents with cobalt chrome implants versus this material. And so a patient who comes into my office, frequently women, but not exclusively women, I would ask, have you ever reacted to stainless steel jewelry in your earrings, in your earlobes? Well, my husband would never buy me anything like that. Well, let's go this a little bit further. Have you ever had a rash or a painful earlobe that developed after some of this jewelry? Oh, yes, I have, but no one ever asked me that question. Well, nickel sensitivity in the United States is much higher than Europe because of nickel salt preparation of leather products. The EU doesn't allow that. It's not restricted in the US, so there are many reasons why people might have more exposures. That's a disclosure that I'm sure will appear on CNN. But there is a reason for it to be a clinical concern and clinical issue. And so for me, I actually pay attention to this. It's actually clinically relevant. And we have patients that have been prevented some of these painful outcomes because we have this unique bearing surface material that avoids the high nickel content. Again, that's just my clinical experience. Now, the hip and knee societies, which are leadership societies, both clinical and research societies, have come out in favor of having codes to identify a different implant material that actually might affect the long-term outcome. Questions? I know this takes a while to get going, so
Thank you, Dr. Snyder. I don't see any questions in the audience, so operator, do you have any clinical questions on the phone lines?
All lines are now unmuted. You may ask your question.
This is Sue Bowman from the American Health Information Management Association. I just wanted to clarify the presenter's comment that this oxidized zirconium is not a type of ceramic, because the top of page 13 in our packet seems to say that it is, and I might have been a little confused the last time this was presented, because I thought at that time it was sort of describing it as a ceramic, but a different kind of ceramic than what the current PCS codes describe. So I just wanted to clarify that point.
Sure, that's a good question. And again, this is still a misunderstanding anywhere in the world where you go, quite frankly, because it's a unique material. It is not a ceramic. A ceramic is a crystalline structure which has been compacted in such a way to create an implant that is ceramic through and through. This is not that. This is a metal that's been treated in a special way with high heat under oxygen conditions that transforms the surface of that metal into a ceramic oxide layer. And as a result, that transformation allows this to still be a metal and perform as a metal, as is a good idea, but in a way that quite frankly behaves like a ceramic without the ceramic risk. That's fundamentally the difference, and this has been published many times and presented many times, but most notably around the world, to gain reason for it to be included in care systems and then tracked in registries.
Thank you.
Are there any other questions on the phone line? If not, then we will proceed with going over the coding options. And if you'll remain up here and answer questions. If you would please turn to page 13 of your handouts, you will see that currently we do assign these services to the body OSR, to synthetic substitute ceramic on polyethylene, and that this is specified in the device key. And that for the knee joint replacement, we use OSR and the device value synthetic substitute. And you'll see the tables at the bottom of 13 that illustrate this. Option 1 would be not to create new codes and to continue using the existing codes. Option 2 would be to create a new device value synthetic substitute oxidized zirconium on polyethylene for the hip and knee joint in table OSR. And as you would see on the table 14, we would add those where their hips and knees are, add device value 6. CMS does not have a recommendation. We would be interested in hearing the audience recommendation on that. But in the meantime, you would continue to use the existing codes. Does anybody have any comments on these options? Anybody in the audience? And just please say your name.
Jean Yoder. Well, we kind of have a problem now because we have the options of ceramic or metal, and so now we've got the statement that it's metal. And we have a problem with metal because the various finishes in metal, we know that some of them, the Dupuis had that little bit of a problem and kind of had all those splinters which caused damage in young people. So we have that thing where we don't like to use metal, but now he says it's metal. And so I can understand that having a special finish on the metal might be important. And so I think it's something that we should certainly consider, this special finish on the metal, though I don't know how many other special finishes there might be on other metal implants. Okay.
Thank you for that comment. Does anybody else have any comment in the audience? Operator, are there any comments on the phone lines?
You may ask your questions at this time.
This is Sue Bowman again. I'd just like to speak in favor of creating a new code. I think last time I was opposed to it because I thought it was too similar to existing codes and would be hard to distinguish, but I thought the presenter did a great job today explaining what the difference is compared to the other bearing surface codes that we already have. So it seems to make a lot of sense to me.
Thank you, Sue. Are there any other comments or questions on the phone lines? Okay, well, thank you so much. We look forward to getting your written comments on this topic. And we'll now ask Michelle Joshua to come up, and she will go over topic 3 on your agenda.
Our third topic for this morning is the administration of Zimplava. This is a new technology add-on payment application, and it is an FDA-approved drug. Here to present Zimplava is Dr. Stephen Marcella. Is Dr. Marcella here? Okay, it looks like we don't have our presenter at the moment, so we will move on to the coding options, which start on page 17. Coding options for Zimplava or bezlotoxumab is not to create a new code, continue to use the current coding option from the table 3E0. Introduction of other therapeutic substance. Option 2, as this is a new technology add-on payment application, would be to create new codes in section X, new technology to identify intravenous infusion of bezlotoxumab. This drug can be administered via peripheral vein as well as central vein. So those would be the body parts in table XW0. Do we have any questions in the audience or on the line regarding the administration of bezlotoxumab or Zimplava?
This is Steve Marcel. I was on the line to present, but apparently I was muted. I'm sorry.
That's okay. So then we will go in then to the clinical presentation by Dr. Marcella. Thank you.
I apologize. So good morning, everyone. And with that introduction, let me just tell you, I'm a physician epidemiologist and work at the outcomes research part of Merck, and I have a colleague also on the phone. His name is Andrew Parker. So thank you very much for allowing us to present this. So we're talking about Zimplava, a monoclonal antibody used to prevent recurrent Clostridium difficile infection. And it's being marketed as a 25 milligram per milliliter injection. And I will guide you through the slides. So the next slide, please. Okay, so the coding issue here is that it is something that we have applied for the NTAP, and there currently is no code that uniquely identify a product such as Zimplava for administration in a hospital setting. Second purposes. It's very significant that it's very hard in the U.S. to get data on what is recurrent C. diff versus primary and first episodes of Clostridium difficile. This will help facilitate that as well as for the NTAP payment. And as I mentioned, Zimplava is being marketed and indicated to reduce the recurrence of C. diff infection in patients 18 years or older who are also receiving antibacterial drug treatment. So I want to emphasize it's for prevention of recurrence. It's not for the treatment of the current infection. And this was approved by the FDA October 21st of last year. Next slide, please. Okay, just a little bit of background for people on the background of C. diff. For those of you who are not as familiar, CDC has identified Clostridium difficile as an immediate health concern to monitor as well as to prevent. In urgent classification, it's a category that requires more monitoring and infection control activities, and this threat is significant because of the following criteria. Not only its clinical impact, it has very substantial economic impact, and it has a 10-year projection of incidence that is very, very significant, which I'll show you in the next slide. There's also issues about transmissibility and also indirect costs that are not even captured very well in terms of isolation and cohorting of patients who have this infection in the hospital. Okay, next slide, please. Okay, just some very brief statistics on the incidence and the burden of Clostridium difficile diarrhea in the United States in 2011, and this was from the CDC. And you can see that there was an estimated total of 453,000 cases of Clostridium difficile, of which approximately 83,000 were recurrent C. diff. So we think this product will substantially or have substantial impact on that recurrence rate. And of those, there's 29,300 that actually had all-cause mortality having to do with C. diff or following cases of Clostridium difficile. Next slide, please. So now I'm going to get a little bit into the product and our clinical trials. So the indications and usage of Zimplava, as I mentioned, it's a human monoclonal antibody. It binds to the C. diff toxin B. It's the first product that actually is an antitoxin for this infection and is actually used to prevent, as I mentioned, recurrence in those 18 years of ages or older. There is a pediatric trial that is being designed currently and is being formulated. Currently, it's approved for those 18 years and older. Limitation of use, it's not indicated for the current treatment. You need to use this with the standard of care, and the standard of care can be one of 3 antibiotics that is in use currently, which is either metronidazole, vancomycin, or fidaxomicin. It also must be used at the time standard of care is being delivered, and that's the way it was designed also in the trials. Next slide, please. There is a warning and precaution with this drug. There was a small increase in risk of, we don't know if it's causal, but there was an association with a small increase in the risk of congestive heart failure, especially with those with a history of congestive heart failure. And in fact, I should read, there were more deaths in the Zimplava-treated patients, 19.5% versus 12.5% in the placebo group of those who already had congestive heart failure. However, the causes of death in that group varied and not only included cardiac failure, but infections, respiratory failure, and others. So we were asked by the FDA to have that as a warning. Next slide, please. Okay, so now I want to get into the clinical studies. So the safety and efficacy was investigated in 2 randomized, double-blind, placebo-controlled, multi-center phase 3 trials, which I'll just refer to as Trial 1 and Trial 2. For a recent publication in the New England Journal, we use the pooled data, but for regulatory purposes, I will just very briefly review the individual trials as we were asked by the FDA. Randomization in these trials, both these trials, was stratified by the actual standard of care. As I had mentioned a moment ago, the antibiotics metronidazole, vancomycin, or fidaxomicin, and hospitalization status, whether the person was inpatient or outpatient at the time of study entry. And as I noted, patients who were 18 years of older and had a confirmed diagnosis of CDI, which was defined as diarrhea by 3 or more loose bowel movements in 24 or fewer hours, a positive test for C. diff, and the patients that were excluded from both of these studies were those where surgery for CDI was planned or imminent, and if they had an otherwise uncontrolled chronic diarrheal illness such as inflammatory bowel disease. Next slide, please. Patients received, as per the usual routine, a 10 to 14-day course of an oral standard of care, and they received a single infusion of Zimplava or placebo administered sometime during the course of standard of care. The median time that this infusion was given was usually around day 3, but varied all the way from about day 1 all the way to day 14. Next slide, please. So here are the results. And pardon me if I know the print's a little bit small. Now, the primary indication for this is, in fact, recurrence, but we were asked as well to have a secondary outcome, the sustained clinical response. And this is the all-comers. This is the whole population in both clinical trials, Trial 1 and Trial 2. I will mention the specific high-risk groups in a moment, but for the purposes of the main results, the sustained clinical response was 4.8%, the adjusted difference. For Trial 1, that's sustained clinical response. And for the sustained clinical response in Trial 2, it was 14.6% difference. Now, I should emphasize that sustained clinical response means that the person had to be cured by a clinical cure by the standard of care treatment, and then go on to have no recurrence. When you look at straight prevention of recurrence, you can see that for the Zimplava group, it's 17.4% in Trial 1. In Trial 2 for placebo, it's 27.6%. So the difference between those two is about 10%. Almost the same exact absolute difference is seen for recurrence in the Trial 2, where it's 15.7% versus 25.7%. So there's basically 10% difference, absolute difference in the recurrence rate for both trials. And I will just mention for the high-risk group for which this is being indicated, which is elderly, people who are immunocompromised, and people who've had prior recurrences or prior episodes, the risk difference, the absolute risk difference varies from about 16% as high as 25%. And what that means is when you have a risk difference of 25%, you would need to treat 4 patients to prevent one recurrent Clostridium difficile episode. Next slide, please. Okay, additional analyses also showed that by 3 weeks post-study drug infusion, the clinical cure rates of the presenting C. diff episode was similar between treatment arms. So we were asked by the FDA to do sensitivity analyses. We in fact did follow these patients to see if there was any difference in the cure rate if we followed them longer. And in fact, as you followed them to about 3 weeks, the difference was minimal. The next slide, please. Just a brief mention on adverse reactions. The most common adverse reactions from Zimplava in those reporting greater than 4% of patients within the first 4 weeks of infusion was nausea, pyrexia, fever, and headache. Serious adverse reactions within 12 weeks following infusion we reported in 29% of Zimplava-treated patients and 33% of placebo-treated patients. So basically, the serious adverse reactions were quite similar. The one difference that I've already pointed out to was there was a small increase in heart failure in the Zimplava-treated patients versus placebo-treated. Infusion-related reactions were mostly minor and were not very different from that of the placebo. Next slide, please. And in immunogenicity, I would just say that there is no antibodies yet seen in the study from those who are given Zimplava. Make that short. And finally, the last slide and the reason for this presentation and request, the recommended dose, as I mentioned, of Zimplava is, well, I didn't mention, the recommended dose is 10 milligrams per kilogram over 60 minutes. It can be infused either via central line or peripheral catheter. And we're requesting a new code to be developed in the section to uniquely identify Zimplava for the reasons I mentioned. Twofold. Number one, because we need to have that for the NTAP to be able to identify adequately. And number two, and as importantly, to be able to do outcome studies on recurrences versus patients who don't have recurrences or patients who had a first episode, to be able to distinguish those different episodes. This would be very helpful as well. And I thank you for allowing me to present and open for questions.
To download the
We're not seeing any questions here in the auditorium. Do we have any questions on the telephone line? Any questions for Dr. Marcella? Okay, thank you, Dr. Marcella. I've noted we have no questions. We will review the coding options briefly again for bezlotoxumab. The first would be to not to create a new code and to continue using codes from table 3E0, which is the administration of other therapeutic substance. And the second option would be to create an X code or a code in table X in the new technology section for the peripheral and central administration of bezlotoxumab. Do we have any questions regarding the coding options presented? Do we have any questions on the telephone line regarding the coding options? Okay, we note that we have no additional questions, and we will move on to our fourth presentation.
Musical chairs. It's like musical chairs.
Okay, we're now on page 18 of the handouts. Our next topic is endovascular cardiac implant. And the issue is that within ICD-10 PCS, there's currently not a unique device value to describe the use of titanium anchor implants to repair the left ventricle internally on an interventricular septum and then externally on the left ventricle following ischemic damage. This is not a new technology application for this coming year, fiscal year 2018. However, the applicant is applying this fall for fiscal year 2019 consideration. I'd like to invite Dr. Wexler to come do the clinical presentation.
To advance this, is this a pointer?
Yeah. Yep. I just put it there.
Okay.
Yeah, it's supposed to be working. We usually use that one, but they put that one. You can use that one to advance.
And this is
slides.
forward, okay. Good. Thank you, Maddie. Good morning. My name is Andrew Wexler. I'm a cardiac surgeon and have been so for about 40 years and have chaired 2 academic university departments of cardiothoracic surgery. And I'm here this morning to show the data that support a request for a new ICD-10 PCS code to describe a hybrid cardiologic and surgical approach to repair damage to the left ventricle. After an acute myocardial infarction, heart muscle becomes replaced by scar tissue. And that scar tissue can stretch and bulge, and then it becomes a ventricular aneurysm. This is particularly true when there are occlusions of the left anterior descending coronary artery, and the consequence of that occlusion is invariably damage to the interventricular septum and to the free wall of the left ventricle. Ultimately, the heart chamber dilates and the contractions become less effective, and many patients progress to heart failure and are referred for corrective surgery of the septum and of the ventricular free wall. In general, these patients have diagnostic codes of I-25.3 and I-25.5. In the past, and the traditional treatment for ventricular aneurysms are twofold. The first is simply excision of the aneurysm. The second is to cut into the scar or aneurysm and to patch the inside of the heart from within the heart. This allows much more effective repair of the damaged ventricular septum and restores a normal shape and volume to the ventricle. Both of these procedures are highly invasive. They require a median sternotomy, cardiopulmonary bypass, incision into the left side of the heart, and oftentimes the heart has to be arrested and deprived of oxygen for some period of time. These are very technically challenging procedures, and they are associated with a high risk of morbidity and mortality, often resulting in prolonged hospitalizations. A new surgical device called the Revivant TC system is being studied in an IDE clinical trial that requires the skills of an interventional cardiologist, cardiothoracic surgeon, and an echocardiologist in order to provide a far less invasive way to correct aneurysm of the septum and left ventricular free wall. This hybrid procedure that I will describe does not require cardiopulmonary bypass, or a median sternotomy, or stopping the heart, or cutting into the heart. It requires only a mini thoracotomy. Myocardial anchors, which I will show you on a subsequent slide, are implanted via a catheter by an interventional cardiologist and cardiac surgeon working together. The heart team ultimately reduces the distance between the two anchors, which compresses the scar tissue on the ventricular septum and the left ventricular free wall. And when a series of these anchors are implanted, it excludes completely the left ventricular aneurysm and septal aneurysm from the pumping chamber of the left ventricle. Now these are the anchors shown here. The internal anchor is placed by the cardiologist against the right side of the scarred interventricular septum. The external anchor is placed by the cardiac surgeon under direct vision, and the two are connected by a tether. When the two anchors are pushed together, this compresses the cardiac tissue, which is scar, between them, and when a series of them are implanted, it excludes the scarred aneurysm from the pumping chamber of the left ventricle. This cartoon illustrates the way the procedure is done. Initially, the echocardiologist demonstrates the thin ventricular septum and free left ventricular wall and shows that they are not contracting or even bulging. The cardiac surgeon makes a mini thoracotomy a few centimeters in length and places a needle from the external scar on the left ventricle across the damaged ventricular septum into the right side of the heart and passes a wire through it to the right side of the heart. The interventional cardiologist, using the internal jugular vein for access, captures the wire that's in the right side of the heart and brings it to him or her. An anchor with a tether specially constructed is then loaded on the wire, and working collaboratively, the cardiac surgeon and the cardiologist pull this anchor through the jugular vein, through the right side of the heart, and place it against the interventricular septum in order to repair it. The cardiac surgeon then places the final external anchor on the tether. This is done in a series of steps that begins just under the aortic valve where the damage initiates and carries down to the apex of the ventricle. And the result of that is shown on this slide. In the top part of the slide, you can see on the right side of the heart, which is on the left side of your screen, within the right ventricle, a row of anchors has been placed against the interventricular septum in order to repair it. On the right side of the screen, the external anchors are paired with the internal anchors, and they have been brought together to compress the scarred tissue and exclude it from the left ventricular cavity. A late follow-up CT scan is shown on the bottom, where you can see the pairs of anchors in apposition with one another, the tissue between the anchors being what was previously the aneurysm of the ventricular septum and the left ventricular free wall, which have now been repaired. The hybrid approach is far more resource intensive than open surgical repair, but in turn it offers patients far decreased trauma and faster recovery. The hybrid approach utilizes a mini thoracotomy and transcatheter techniques and is more complex than the traditional open surgical repair. The hybrid approach also requires the purchase of specialized equipment in order to perform the procedure. However, a full chest incision is avoided, cardiopulmonary bypass is avoided, surgical excision of the heart is avoided, and in a large European study that was used to obtain CE mark approval, patient outcomes and relief from heart failure symptoms were similar to surgery and greater than guideline-directed medical management. So in conclusion, the hybrid procedure, as I've described it, is currently not defined by any established ICD-10 PCS code. A new code is required to describe the hybrid technique for left heart repair, and we suggest it be thought of as a mini thoracotomy with endovascular or transvenous surgical techniques. The hybrid left heart repair procedure is only performed on hospitalized patients where an ICD-10 PCS code is required, and hospitals are asking for coding clarifications on the hybrid technique. The existence of a specific code will enable the procedure to be tracked for hospital and outcomes data, and it is the plan to apply for new technology add-on payment. That too requires a distinct ICD-10 PCS code. Thank you very much for your attention. I'm happy to answer any questions.
Good morning.
Morning.
I'm Linda Holtzman from Clarity Coding. Could you go back to the slide that showed the two physicians and other clinicians? I'm sorry if I'm going to ask you to repeat yourself, but I didn't really understand the surgical technique involved. From what you were describing, I had this notion in my head of the ventricle being collapsed on itself, which I know is not what you're doing since it does have to continue pumping. So it's not clear to me step by step exactly what's happening. Would you mind terribly going through that one more time?
Sure.
Thank you.
I'm sorry, the pointer is non-functional, but I can do it without it. So the heart is beating and in its normal position.
I have a pointer. Would you like it?
Sure. You are well prepared.
Good for you, Linda.
Okay, so this is what the cardiac surgeon sees: a full beating heart that is still working and not distorted but in situ. He also sees the scar on the surface of the left ventricle, and under direct vision is able to put a needle through that scar which traverses the interventricular septum and ends up on the right side of the heart, the right ventricle. And then a wire is put through that needle, and the wire in general is floated out into the pulmonary artery, perhaps in excessive detail. And that's the wire that the interventional cardiologist, by putting a catheter through the internal jugular vein, is going to capture and exteriorize so the anchor and tether can be loaded onto that wire and subsequently delivered through the catheter to the right side of the septum to initiate the septal repair. Clear as mud?
So far, so good. But you said that the two are connected, the internal anchor and the external anchor are connected?
Correct.
So tell me how they're not coming together.
So initially, this internal anchor and the tether are loaded onto the wire, delivered into the right side of the heart, and exteriorized by the cardiac surgeon pulling on the wire which is attached to the tether. It's then that the cardiac surgeon adds the external anchor, which is now sitting on the outside of the left ventricle, and then the two get squished together.
Where is the internal anchor at this point? It's sitting on the inside of the free wall?
It's on the inside of the ventricular septum in order to repair the septum.
What am I missing here, Jean? Right. I got it. Yeah. So you basically are bringing the two walls of the ventricle together.
That is correct.
Okay, so we've got the ventricle here, and you're not squishing this together. You're squishing this together.
It's a little hard for me to know which part of the heart your hands represent, but
okay, here's the left ventricle, okay?
Yep.
You're not putting these walls together because you still need an open chamber to pump, but you are putting these walls together at the bottom,
Remember,
at the apex.
Not just at the apex, but all the way along the length of the left ventricle, wherever
Where
the
the
scar
scar
from the
is.
heart attack has created the thinning and non-contractile portion that, under normal conditions, a surgeon would manage by cutting directly into it and then doing an internal repair. All of that's completely avoided.
So you are essentially opposing those walls and reducing the size, in a sense, of the left ventricular chamber.
That's absolutely correct.
Thank you, Jean. Thank you, doctor.
Thanks for your pointer. I've always wanted one of these.
Hi. From coding's perspective, I'm kind of mainly into coding. This actually to us an implantation of something, so it's kind of confusing to say this is a repair. Would it correct to say an implantation because you put the titanium anchor inside the heart? So for us, we would find the code, index it at implanting.
Good, I understand that. That's right. We are implanting this series of anchors in order to repair the heart.
Okay, so when time for discuss proposal codes, I may have some question about it then.
Sure. Okay.
Do we have any clinical questions on the phones for Dr. Wexler? Okay, we're going to go ahead and turn to the coding options now. On page 19 of the handouts, the current coding would be repair of the ventricular septum with a percutaneous approach, and also repair of the left ventricle with an open approach. Under the coding options, option 1 would be do not create new codes. You would continue to code with the current coding. Option 2 would be to create new codes in section X, table X2Q, to identify this combined internal-external technique for repairing the left ventricle, and then you would also continue to code from table 02Q for repairing the left ventricular septum. You can see what it would look like in the table. CMS does not have a recommendation at this time. We are interested in hearing comments because this is a unique type of technology and procedure. So please come to the microphone and identify yourself if you have comments or questions for the coding.
I would suggest with new codes, but should the qualified be implantation titanium, so make us seem more accurate, you repair it, qualify with implantation of titanium. That's my suggestions.
Can you send in your comments? Your written comments, thank you.
Nellie Leon, she's saying, I know it's very difficult to create the right wording for new technology, but I agree, repair just seemed a little bit too vague for me in the sense that we have been trained that repair is sort of the root operation of last resort when you can't figure out, what other root operation should apply. But also, when I look at the column for device, substance, technology, I'm expecting to find something that would tell me what the device is, like titanium anchor or something along those lines, as opposed to saying, well, you're combining internal and external repair technique. So technique doesn't scream to me that it's some sort of a device. So if I would look at this, if I hadn't seen the rest of the presentation, I would have no idea what was being done. So I understand internal or external repair is very unique. It's very exciting that this is being done. That's why I was paying close attention to the diagram trying to follow the doctor, which was a very, very good explanation. But with this code descriptor, I don't even know what this procedure is. So I would suggest somewhere in there that there's something about titanium anchors or something along those lines.
Okay, thank you, Nellie. So just before you step away, would you agree with the Section X coding for that and just revising the terminology, or?
Good question, because in previous meetings, my gut reaction has been that if there is an existing body system, right, we have cardiovascular system, if there's an existing root operation, then we should try to fit those procedures within the body of all the other procedures. But the reason why I say it's an interesting question is that every time I've made that recommendation, it's never been taken up. So I don't really know if there's something internally within the CMS structure of PCS or your internal systems that you prefer to have them under a section called new technology. But my inclination has been that really, whether it's new technology requiring or being approved for an add-on payment should be something separate from the PCS structure. So if you really want to know what I think, I would not have it under a new technology section. I would put it into the main body of PCS codes.
Okay, I'm just going to throw an option out there. What would you think about supplement with a synthetic substitute?
I actually had thought about that initially.
Okay.
Supplement would have been like my first thought, but I know that's always kind of difficult for people to understand. Are we really supplementing? And I was listening very carefully to Linda's question, because that's what I was trying to figure out. Repair from the get-go did not seem right to me, but I didn't know if it should be insertion or are we really supplementing we're trying to kind of bring the scar tissue back to what it, the normal heart muscle was. So supplement feels better definitely than repair.
Okay, thanks, Nellie.
Lynn Keene Consulting, and after all that discussion, I was originally going to say that I did not advocate for this code at all, but then you said they were going to apply for a new technology add-on payment?
For fiscal year 2019, so they'll submit their application this fall.
Okay.
So the other option is to bring it back. That's always, an option as well.
Okay. It does seem like this will probably end up to be something that's used a lot, even after the new technology add-on payment goes away. And really, for the root operation, I believe it should be supplement, because I like to think of repair with a device equals supplement. And the mention was made clinically that the septum has now thinned out. So it is being supplemented by these two devices. So I really like your suggestion of supplement with a synthetic substitute. Okay. And I would really like it in medical and surgical where it belongs. All right?
Thank you, Lynn.
Linda Holtzman, Clarity Coding. I don't like repair either. So I'm just jumping on everybody else's comments. And I can see supplement. I can see that. But maybe you could also consider restriction.
I have that noted as well.
Right.
Thank you.
And the reason I mention restriction is because I know that it's not a tubular body part, but it does have an open chamber. And we are closing off that portion of the chamber. And we already think restriction when we think aneurysm. So this may be a good match. So, okay. Well, I guess I don't think of it as tubular, in the sense that it's not a vessel, so to speak, or a duct or something like that. But I did go in that direction because I thought, well, it's got an open space in it. Plus, we already go for aneurysm to restriction, so maybe that would be more intuitive. Just a thought. We might need to tweak the definition of restriction, or at least publish something that says, according to Gene Yoder, the heart is a tube. So either way, I'm open. So just another possibility for this.
Thank you,
Thanks.
Linda. We have another comment.
Laurie Johnson, Panacea Healthcare Solutions. The other thought that I had that might create some concern or debate is the approach, because we have a percutaneous approach and an open approach both done at the same time. So the question, do we need to create a new approach which would be hybrid? I know, I hear the groaning. Or do we have to put something in the guidelines that if there is a hybrid, that open is the default? So just a
You can send in your comments. We appreciate and evaluate everything. Okay, I want to open it up to the phone lines for questions or comments on the coding options.
This is Sue Bowman from AHIMA. I actually like the idea of supplement as the root operation. I think I'd like that better than restriction, although I'd have to give it a little bit more thought. But I definitely support putting this in the med-surg section rather than new technology. Like Nellie said, if it fits in a body system table, I'd rather put it there than just put everything that happens to involve a new technology procedure into the new technology section. So I'd rather see it in med-surg.
Thank you, Sue.
Lynn Keene again. Speaking to the supplement versus restriction, we have a procedure, and kudos to the cardiologists who figured out how to do this. It is open and percutaneous, and it is supplement and it's restriction, and it really works. So we can't really, if you want to keep this as a bundle, you have to decide on something. And so it doesn't really restrict the septum, it only restricts the ventricle. So if it goes back to medical and surgical, then what we need is restriction of the ventricle. We already have supplement for the septum. If you want to keep it together, though, if you end up putting it in new technology, which I'm hearing that we don't like, but I think it should stay as supplement then. If it needs to stay as one unit in new technology.
Thank you, Lynn.
I think the end intent is to, okay, I don't know, and it's a good thing you're sitting there now, because here it is the intent to make it so that the septum is stronger, or is the intent to restrict the large size of the ventricle so that it pumps more properly? What's the intent here? Okay?
So the intent is not to strengthen the septum.
Okay, so we're not supplementing the septum.
It's to eliminate the aneurysm
Okay.
from the interior of the left ventricle.
So we're restricting the size of the ventricle?
Yes.
Okay.
Great question and great answer. Because when we were initially trying to understand ICD-10 PCS and how to apply the root operations, and we were looking at how to repair aneurysms, because it's an ICD-9 CM, it was a single code repair, we debated back and forth between restriction and supplement and had to figure out what are you actually doing with each different type of aneurysm repair. So thank you, doctor, for being here and providing that clarification. I think that restriction seems like a better fit, but I think the challenge, as Lynn just mentioned, is that we're trying to smush together in a single code a very complex procedure where you're partly doing something to the septum, then you're doing something different to the ventricle. So perhaps think about whether you want to split it up into two codes to actually describe what's being done, or do you want to just sort of say, well, what's more important? Do you want to put it into just one code and call it restriction and identify that there are these titanium anchors being used and kind of rely on people being able to figure out what the code means?
Thank you, Nellie. Are there any other comments from the phone lines or questions?
All lines are unmuted.
Okay, doesn't sound like there's any more comments from the phone lines. And with all the comments and taking into consideration, it sounds like we might need to bring this one back in September and put out a couple more options for consideration. Now, as far as the interim coding advice, as it states, it's under current coding. We have repair, and nobody likes that. All right, David. Yeah, well, okay, let me just see by a nod of heads. Are you okay with the current coding, coding it to repair?
You're restoring the blood part to its normal structure and function.
Maddie, you have to insist they come to the microphone.
Okay. Okay, it sounds like we're okay with the current coding advice then, and we'll just leave it simple instead of complicating things. So we'll look to bring the coding options back at the September meeting. Thank you very much, Dr. Wexler.
David, microphone or not talk?
Sorry.
All right, Dr. Berglund's going to come to the mic.
Sure. Sorry. Sorry, I don't usually like to jump in and comment because we've got a lot of wonderful people who have a lot of good things to say here. But I do think one of the issues here is what words we have and how some of these words we're using in ICD-10 PCS might, in context, have slightly different meanings than they might in other cases. And I think from what I would see here, I think our objective here is to restore the function of the heart and to restore the, well, you can, if we look at 10 PCS, we're trying to restore the structure and the function of the heart, and that's the general idea. So yeah, we sort of restrict an aneurysm in order to do that, but we're still trying to restore the normal structure and function. At least that's the idea. I would defer to our surgeon to say how that's done, or if he agrees with me, of course, because I'm not an expert on this, but I think that's the idea of the main purpose of what we're trying to do.
Yes, in fact, the name of the open traditional procedure was called surgical ventricular restoration. So.
Okay. Thanks. Just glad to weigh in slightly, and thanks.
Thanks, David. We look forward to your comments. Written. Yes, I encourage all of you to send in written comments so we can evaluate this closely and bring back additional coding options at the September meeting. And we agree that the current coding, the interim coding device, stands for now. Okay, moving on to the next topic. If you turn the page 20 in your packets, combined thoracic aortic arch replacement and descending thoracic aortic restriction. So currently within ICD-10, there is not a unique device value to describe a dual-purpose graft that combines thoracic aortic arch replacement with descending thoracic aortic restriction. So this technology has been designed for patients with complex and diverse aortic arch disease or trauma. An IDE clinical study is currently being conducted, and therefore the request for a new code for device value to identify this technology and assess clinical outcomes is going to be discussed. I'd like to bring Dr. Lemaire up right now, and this also is not a new technology request for fiscal year 2018. They too will be applying this fall for fiscal year 2019 consideration.
Good morning, everyone. I'm Scott Lemaire. I'm a cardiothoracic surgeon at Baylor College of Medicine and the Texas Heart Institute, and I'm in a practice that focuses primarily on the treatment of patients with aortic aneurysms and aortic dissections. So my task this morning is to describe the rationale for requesting a new ICD-10 PCS code to define a new, unique, novel hybrid device and surgical procedure to repair or replace diseased or damaged vessels of the ascending thoracic aorta, aortic arch, and descending thoracic aorta during a single procedure known as the frozen elephant trunk technique. Now, currently, repair techniques involve two separate surgical procedures, usually requiring two distinct hospitalizations and two grafts. Surgical repair only occurs in the inpatient hospital setting where ICD-10 PCS codes are required. Through current coding, there is no means to capture procedure, utilization, cost, and outcomes data. Hospital coders understand how to code for staged procedures, but are unclear on how to code for a hybrid repair and replacement procedure when performed as a single surgical intervention involving an integrated hybrid device. So I'll briefly describe the patient population, review the current treatment procedures, describe the unique surgical procedure enabled by the new Thoraflex hybrid device, and then provide some clinical details. So this procedure is performed in patients with diseased or damaged aortic vessels involving complex and diverse aortic arch diseases or trauma. And these are the current ICD-10 CM diagnosis codes that would be applicable to patients undergoing this operation. So this is a diagram of the entire aorta, which is divided into two major components, the thoracic aorta above the diaphragm and the abdominal aorta below the diaphragm. And then the thoracic aorta is further subdivided into three major sections. The ascending aorta, located immediately distal to the aortic valve and ending at the level of the innominate artery. The transverse aortic arch, which is the short section of the aorta from which the brachiocephalic vessels arise, supplying blood to the arms and the head. And then the descending thoracic aorta extending from the left subclavian artery down to the level of the diaphragm. And when disease involves this entire thoracic aortic component, generally requires two separate operations in order to repair the entire aorta. So aortic arch repair is technically very challenging with a high risk of death and stroke. And when disease of the arch and extends into the descending thoracic aorta, as shown in this drawing here, a two-stage repair is commonly required. The first stage entails replacement of the ascending aorta and transverse aortic arch with an elephant trunk graft. And then the second stage entails restriction of the descending thoracic aorta with an intraluminal graft delivered via either an open or endovascular approach. So this is how we currently do the procedures. This is the first stage, open repair of the ascending aorta and arch, and you can see that the descending aorta is also dilated. And the first step is to reconnect the brachiocephalic vessel supplying blood to the arm and the heads using this double Y graft. So that's sutured onto these blood vessels, and after that's been placed, then under cardiopulmonary bypass and circulatory arrest, the ascending aorta and aortic arch are opened, and the conventional elephant trunk graft is placed into the aorta. So this is the conventional graft. It's a Dacron graft with no stent component. It's slipped into the descending thoracic aorta so that that distal end of the graft is then left suspended in the descending thoracic aorta, which will facilitate the second repair. The collar of the graft is then sutured to the aortic arch, the graft is clamped and perfusion restored, and then the proximal portion of the graft is used to replace the ascending aorta, just distal to the aortic valve, and then the branch graft going to the head vessels is reattached to the graft. So this would be the completed first stage open operation in this sequence. And this is the current ICD-10 PCS procedure for that first stage open repair. Then, after a period of several weeks after the patient has recovered from that first operation, they would come back to the hospital for a second operation, whereas the first operation is performed through a median sternotomy. This one would be performed through a left thoracotomy or thoracoabdominal incision. You can see there the conventional conventional elephant trunk graft is suspended in a descending aorta. What happens is the aorta is clamped, and then that old graft is pulled out of the aorta, and then a new graft is sutured end-to-end to the existing elephant trunk graft. And that new graft is then used to replace the aneurysmal descending thoracic or thoracoabdominal aorta in this second stage open operation. And here is the current ICD-10 PCS procedure code for that second stage open operation. Now, alternatively, in some patients, you can actually use an endovascular approach to complete the second stage procedure if they have suitable anatomy. And so here again is the conventional elephant trunk graft suspended in the descending aorta, and by a transfemoral approach with a guide wire and sheath inserted up through the aorta and into the inside of that elephant trunk graft, a stent graft can then be deployed. So the proximal landing zone is inside the elephant trunk graft, the distal landing zone into the normal diameter aorta beyond the aneurysm, thereby excluding the entire aneurysm and completing the repair. This is a patient of ours who underwent this type of a procedure. So the first stage was replacement of the ascending and aortic arch. You can see the conventional elephant trunk graft there. And then a second stage procedure was completed with a stent graft. You can see the wire frame of the stent graft on the imaging. That was landed inside the elephant trunk graft, and then distally in the normal diameter aorta. So a two-stage approach to replacing the entire thoracic aorta. And this is the current ICD-10 PCS procedure code for the endovascular approach to that second stage procedure. Now, the Thoraflex Hybrid is a new device that replaces the ascending thoracic aorta and aortic arch and restricts the descending thoracic aorta in a single procedure. It's typically performed by a cardiothoracic surgeon during an operation that takes about 6 hours. And the descending aorta is restricted by placing the distal stent of the device in an antegrade transluminal approach through the transected aorta into the descending thoracic aorta. The device is then secured by suturing an integral collar portion of the product to the distal native aortic remnant. And then the ascending aorta and aortic arch are resected and replaced with a proximal non-stented portion of the device. This device is currently in an IDE clinical trial and is available in various sizes and 2 configurations. And here are those 2 configurations, and I'll describe the difference briefly in a moment. But the key point here is that there's a proximal portion of the graft. It's the surgical graft for the ascending on the left, and then on the right is shown the distal stent portion that's related for repair of the descending thoracic aorta. And so the first configuration is known as the plexus device. It enables individual arch branch reconstruction. So you can see those arch branches coming off of the surgical portion of the graft, and that's then used to reattach the innominate left common carotid and left subclavian arteries. Alternatively, you can use the anti-flow graft, and that allows the island technique of reattaching the head vessel. So then rather than putting individual grafts to each of those brachiocephalic vessels, an opening is cut in the aortic graft, and then an island of aortic tissue is sewn directly to that opening so that the brachiocephalic vessels are reattached as a single group. And both techniques are popular at various cardiovascular centers. Now, the Thoraflex Hybrid device is preloaded into a delivery system designed to offer safe and accurate delivery. And so what you can see here is the delivery system Here's the proximal surgical graft is actually located in the handle component of the delivery system, and then the stent is actually compressed and compacted onto the distal end of the delivery system within a sheath. That sheath is flexible and can easily be inserted into the aorta through the open aortic arch. So as you see, as you pull the handle of this delivery device, the stent graft then deploys in the location that you've placed it. So what this looks like in the operating room is through the open ascending aorta and arch, the delivery device is introduced into the descending thoracic aorta as shown here. The handle is then pulled, that then deploys the stent graft in the descending thoracic aorta, landing it distally in the normal diameter aorta. The delivery device is then removed, leaving behind the surgical portion of the graft that's used to replace the ascending aorta and transverse aortic arch. So here you have a completed repair of the entire thoracic aorta with a single device and a single procedure. So this device combines two surgical procedures into one, the open repair of the descending thoracic aorta by introducing the device distal stent transluminally into the descending thoracic aorta, followed immediately by open surgical repair to remove and replace the diseased and damaged ascending thoracic aorta and aortic arch with a proximal graft section of the device. This device has been used for frozen elephant trunk extensively, particularly in Europe, and has been shown to allow earlier patient rewarming, reduced myocardial and lower body ischemic times, and reduced operating times. Implantation of the Thoraflex hybrid device has resulted in excellent outcomes and beneficial aortic remodeling during follow-up based on information from the group in Hanover. And the group in Bologna has recently published on the ability to use the four-branched arch graft to increase the spectrum of techniques available for the surgeon in the treatment of complex diseases of the thoracic aorta. So in conclusion, the single open surgical device enables a single stage operation using the frozen elephant trunk technique, one hospitalization instead of two, reduced surgical trauma with elimination of the second stage, potentially improved patient outcomes, and increased efficiencies including reductions in cardiopulmonary bypass time, ischemic time, rewarming time, etc. A new ICD-10 PCS code is required to describe this new single-stage procedure using a hybrid device, and there's intention to apply for a new technology add-on payment. Thank you for your time, and I welcome any questions.
Can we open up the phone lines, see if there's any clinical questions?
All lines now unmuted.
Okay, we'll move on to the coding options on page 21 of the handouts. As it was listed in the presentation, the current coding for reporting this type of procedure would be the replacement and restriction root ops. Option 1 would be not to add new device value to table 02R, continue to use the codes as in current coding, and to identify that the patient is in a clinical trial, you could report the ICD-10 CM diagnosis code Z006. Option 2 would be to create two new device values in section X, table X2R, for branch synthetic substitute with introluminal device, and Y synthetic substitute with introluminal device, to identify the replacement and restriction with the various configurations. As you can see, the rationale that we have is that while it is a single medical device, it's completing two distinct procedural objectives. And to lose that, it could impact the data. You can see the coding option in the table, what it would look like. The next page, 22. We don't have a recommendation at this time. We'd like to hear comments from the audience. I see Linda and Lynn.
Lynn Keene Consulting. I just have a question, Maddie. So you're advocating both the new technology, addition of the devices, And then also, why is the 02V table there then on page 22? I just don't understand.
Because there are two different root ops, so we're proposing to code the replacement with the actual device for the ascending, the thoracic aortic arch, and then to use the restriction code for the descending thoracic aortic arch.
So one from each section then?
Yes, so it would be two codes, but the new technology would be identified in the replacement root op.
Well, my recommendation would be then to not do that. I don't see why we shouldn't have a branched synthetic substitute in the replacement table all the time.
In the main section.
In the main section, and then use the two codes, because as you mentioned, you lose the detail if you have one in one place and one in the other.
Okay, so you would support having the two codes, but the main section for the replacement root op?
Yes.
Okay, thank you.
I'm Linda Holtzman from Clarity Coding. In the interest of full disclosure, I'd like to note that I sometimes do consulting for Medtronic and for Cook, both of which have endovascular stent grafts for the aorta. Also, I was one of the coders who worked on the ICD-10 proposal that gave us the current 02V. And to tell you the truth, when you started talking about making some changes, I just got the willies. So I have to think this through a little bit more. But I like to agree with Sue, I really do, but I don't this time. I do see two separate root operations here. It's pretty clearly a replacement on one and pretty clearly a restriction on the other. I understand completely, especially with an NTAP, that you need to find a way to identify the use of this device distinctly. But I think that can still be done with the use of both codes. I mean, in the conventional procedure, you said that it's staged. So the first stage would have the replacement, and the second stage would have the code for the restriction. So it's easy to identify the conventional procedure because you have two separate claims. If this device is used, you could uniquely identify it because you'd have both codes on the same claim. So that would enable you to identify that it was a single stage procedure. And that's what your device accomplishes. So, notwithstanding the fact that I have the willies about fiddling with this, although I myself fiddled with it last year, so I really shouldn't say that, but I'm kind of inclined at this point to leave it alone and still be able to identify your device by the combination of the two codes and the combination of the two root operations, both of which are taking place. I'll give it some more thoughts and have a cup of coffee and relax, decaf, get over the willies.
You have till April 7th.
Right, yeah, and think it through. Thank you.
That's a terrific question. There are times when we can currently do these in one operation without this new device, and that is done from time to time. And that would be done with a conventional elephant trunk graft, and then during the same procedure, having a stent graft inserted and landed into that conventional elephant trunk graft. Sometimes it happens during a different hospitalization. Sometimes it happens during the same hospitalization after a couple of days of recovery. And sometimes it happens during the same operation. And in those cases, the stent graft can either be delivered from the femoral artery or can actually be delivered through the new graft that you've been placed in. And so there will be times when you would have both codes during one day or one operation, but it wouldn't distinguish whether you used the device, one single device, or you used multiple devices. That'd be the only clarification I'd make to that point, but I think it's a fantastic point.
Do we have any comments on the phone lines at this time? We'll open it up again.
This is Sue Bowman from AHEMA. I would just like to support Lynn's suggestion of creating the new replacement codes in the replacement table in the med-surg section rather than a new technology.
Thank you, Sue. Any other comments from the phones? Okay, are there any other comments here? Okay. Well, we look forward to your written comments. They're due April 7th. Thank you.
Do we have Dr. Mary Gellens here? Yes, wonderful. Okay. You come up. Our next topic is renal replacement therapy. Currently, there are no unique ICD-10 codes to capture the duration of a dialysis procedure. This makes it challenging to track prescribing patterns as well as to evaluate the efficacy of treatment modalities with renal replacement therapy. This is not a new technology application, and it is an FDA-approved procedure. Dr. Mary Gellens is here to provide a clinical presentation of renal replacement therapy. Dr. Gellens, thank you.
Thank you very much for the opportunity to present today. My name is Mary Gellens. I'm a nephrologist from Baxter Healthcare. Okay, so we're here today to ask for new procedure codes for renal replacement therapy in the hospital. Renal replacement therapy is dialysis therapy. So dialysis is used for patients with renal failure. There's two different kinds of renal failure. There's chronic renal failure, which happens when you have either diabetes or high blood pressure for a long period of time, and your kidneys fail over time and they won't recover. So the dialysis used for that is either hemodialysis or peritoneal dialysis. The kind of renal replacement therapy we're discussing today is renal replacement therapy which is used for acute kidney injury. So acute kidney injury is different than chronic renal failure. Acute kidney injury occurs when you have acute injury, like an overwhelming infection or major trauma or complications from a surgery or something like that. So that's acute kidney injury, and the dialysis that's used for acute kidney injury is a little different and a little more complex than the dialysis that we use for chronic kidney disease. Patients with acute kidney injury oftentimes do recover kidney function. So currently, there's only 3 codes that exist for renal replacement therapy in the hospital, and there's one for peritoneal dialysis, and the other one is for hemodialysis. The issue, however, is that peritoneal dialysis and hemodialysis and renal replacement therapies have distinct profiles of use, benefits, and risks. So due to the lack of specific codes for renal replacement therapy for acute kidney injury, we feel that additional codes are needed. So currently, one type of dialysis is peritoneal dialysis. This is the kind of dialysis that is primarily used for patients with chronic renal disease in the home setting. So this is where a catheter is put into your abdominal cavity and fluids are infused in and drained out, and that takes away the toxins and the extra fluids. Hemodialysis is a different kind of dialysis, and this is the kind of dialysis where blood is filtered through a dialysis machine and a dialyzer, and toxins and extra fluids are removed. For acute kidney failure, the types of hemodialysis that you can use are a little bit more complex than what's used for chronic kidney disease. So you can use conventional intermittent hemodialysis for acute kidney failure. That's prescribed for like 3 to 5 hours a day and can be done every day or 3 times a day or 5 times a day or whatever is necessary for the patient. These other 2 kinds of dialysis that are used for acute kidney failure are prolonged intermittent renal replacement therapy, otherwise known as PERT, sometimes known as SLED. So this kind of dialysis is practiced for a much longer time. So instead of the 3 to 5 hours, this is often prescribed for 6 to 18 hours and is a much slower and gentler dialysis for patients that are much more acutely ill. The other kind of hemodialysis that's available for acute kidney injury patients is continuous renal replacement therapy. And this kind of dialysis is prescribed over a 24-hour period. This is the most gentle, the easiest kind of dialysis for a patient to tolerate who is severely ill. And the continuous renal replacement therapy incorporates another technique besides just hemodialysis, also hemofiltration, which is another way of removing different size toxins when patients have acute kidney injury. So it's the kind of dialysis that can be provided in the hospital for acute kidney injury is more complicated. So the current ICD-10 codes don't adequately specify the duration of the dialysis procedure. The current codes for hemodialysis are only descriptive as far as whether or not it's a single episode of treatment or multiple treatments. There's no specificity to the duration of the treatment. So based on these existing codes, you can't really determine what kind of dialysis the patient is getting for acute kidney injury. So our proposal is that the ICD-10 codes need to capture the duration of the dialysis procedure, whether it is conventional hemodialysis, prolonged intermittent dialysis, or continuous renal replacement therapy. With this kind of coding then, it will facilitate the tracking of the renal replacement therapy procedure relative to utilization and prescribing patterns for hospitalized patients. So the new codes will then allow better evaluation of patient clinical outcomes for critically ill patients requiring renal replacement therapy as a life-sustaining therapy, because currently you don't really know what kind of therapy patients are getting in the ICU for acute kidney injury. It's not really clear which one they're getting. Thank you. Happy to take any questions.
Operator, will you open the line for questions?
All lines have been open.
Do we have any questions on the telephone line? Okay, if you'd like, you can stay here for just a second. Thank you. Okay. We'll proceed to the coding options, which, if you're following in your agenda, is on page 24. Current coding: if desired, facilities can report renal replacement therapy with one of the following ICD-10 PCS codes. We have codes from Table 3E1, irrigation of peritoneal cavity using dialysate percutaneous approach. We have codes from Table 5A1, performance of urinary filtration single and performance of urinary filtration multiple. Coding options include: option 1, do not create new codes for renal replacement therapy. Continue using the existing PCS codes as just described. Option 2, delete existing renal replacement therapy codes in Table 5A1, performance of urinary filtration single and performance of urinary filtration multiple. In Table 5A1, route operation of performance in the extracorporeal assistance and performance section, we would add a new row to the table containing the body system value urinary, the duration values intermittent and continuous, and the function value of filtration. And you can see that option on your slide. Option 3, being similar to option 2, we would delete the codes in Table 5A1, performance of urinary filtration single and performance of urinary filtration multiple. In Table 5A1, route operation performance in the extracorporeal assistance and performance section, we would create new duration values. There would be an intermittent less than 6 hours per day and an intermittent between 6 and 18 hours per day. And for continuous, we would have the option of greater than 18 hours per day. Those would be applied to the urinary body system and the function value filtration. That is depicted also on the bottom of your slide. CMS recommends option 3, deleting the existing codes in Table 5A1 and creating new duration values as described above. Our interim coding advice would be to continue to report renal replacement therapy as described in the current coding options. Do we have questions? I see we do. Thank you.
I don't have question, but I have comment. I support number 3 as of right now in documentation for the option 2 is hard to index that intimate continue and so on. We couldn't determine in records. So we are really troubling finding correct code for dialysis in our hospital.
Thank you.
Nellie Leon, she's saying, actually mine is a question rather than a recommendation. For option 3, the breakdown for intermittent is less than 6 hours per day, and the next intermittent is 6 to 18. And so I was wondering how you came up with that number of hours, because on page 23, the example for intermittent talks about 3 to 5 hours per treatment. And then prolonged intermittent being 8 to 12 hours. So it seems like, were you trying to pick something in between, a little bit over? I'm not sure, what's the magic about 6 hours?
And I'll have Dr. Gellin address the question.
Yeah, thank you very much for the question. So, yeah, it has to do with the nephrologist and how they want to prescribe the therapy. So on chronic dialysis, on the outpatient setting, most patients get 3 times a week, 4 hours. That's it. Chronic setting, they come in 3 times a week, that's it. But at the acute setting, the needs of the patients are all different. So actually, one patient may get more than one type of therapy during the course of their illness. So when they're super sick with no blood pressure and their kidneys don't work, you would be more likely to use the continuous therapy, which is 24 hours, because then you can very slowly take off the fluids and the toxins, and their blood pressure will be able to handle that. Now, they get a little bit better, well, maybe get a lot better, then you can go to the conventional hemodialysis, which is 3 to 5 hours, maybe 3 hours, 5 days a week, depending on, how much fluids and toxins they have, or maybe they're really stable and you can do 4 hours 3 times a week. So it has to do with this patient population, which is very variable as far as what their needs are during the course of their illness. So that's why we have for less than 6 hours, because typically that kind of conventional hemodialysis anywhere from 3 to 4 to 5. Somebody might even do 2 hours every day, depending on the needs of the patient. And then there's this middle of the road dialysis, this PERT, prolonged intermittent renal replacement therapy. Now that kind of dialysis can go on for like 6 to 12 hours, but depends on the needs of the patient. Maybe they only needed 6 hours 5 days a week, or 8 hours 5 days a week. It also has to do with the technology, actually, because the first 2 kinds, the less than 6 hours and the prolonged intermittent renal replacement therapy, can be done with a typical dialysis machine. The last one, the continuous one over 24 hours, that can be a whole new device that you use. Okay, and that's for the really sick people. So the hours have to do with the needs of the patient, how much fluid they have to take off, how frequently you can do it, and how much toxin they have. But go ahead.
I understand that it would vary, but it just seemed to be a little bit at odds with the numbers that were used on page 23, because it sounded like 3 to 5 hours was one cut off, and then the next one was starting at 6. So I was just wondering why it was 6 instead of 5 or 4. But it sounds like there are limitations also with the machine. So
right.
Okay. Thank you.
Sure.
Thank you. Do we have additional questions? Okay. Thank you. Then we will move on to our next topic. Thank you, Dr. Gellin.
We'll now turn to topic 7, radiotherapeutic brain implant. And the issue is that there is not a unique ICD-10 PCS code for the gamma tile, which is a radiotherapeutic brain implant used for the treatment of brain tumors. There is an application for new technology for fiscal year 2018. It is not yet FDA approved, but it is anticipate getting approval before July 1st, 2017. And to discuss the clinical issues of this, I would like to introduce William Cavanaugh, the Chief Operating Officer and Chief Scientific Officer for IsoRay Medical Incorporated.
Thank you, Pat, and thank you, everybody. I have to say it's been interesting this morning and even a little bit of fun watching how you guys do what you do. I'm Bill Cavanaugh. I'm with IsoRay. I'm actually here on behalf of both IsoRay Medical and Gamma Tile LLC, which is a collaborative of physicians working on what we are calling the Gamma Tile. And I'll explain more about what Gamma Tile is, why it's distinct, and potentially has the potential to change the way we look at radiation therapy inside the cranium. There is, as stated already, there is currently no unique ICD-10 PCS code to capture the use of gamma tile, and as Pat said, we have applied for an NTAP. The clinical issue, the clinical space we're trying to address here are recurrent, we're saying broadly intracranial neoplasms, but colloquially we would say recurrent brain cancers. The brain cancers can either be primary or metastatic. You can see the 50,000 cases per year recurrent metastatic brain cancers. These are the cancers that originate from the breast, from the lung, from the renal cell carcinomas, melanomas, others that cannot be controlled in their primary setting. They metastasize. They have a propensity to get into the brain for whatever reason, still a mystery. But once they get into the brain, they can become a challenge. Many can be addressed first time through. When they recur, they become a real problem, as you might imagine. Because wide surgical excision of brain cancers is not always possible, adjuvant therapies are very frequently employed. Adjuvant therapies are to assist in the control of the cancer when surgery is just not always complete. A complete excision is not possible. Adjuvants in the treatment of brain cancers can be either chemotherapeutic or radiotherapeutic. Chemotherapy-based, you're all familiar with that. Radiation, of course, works to a completely different mechanism from chemotherapy. Chemotherapy is hindered badly by the difficulty in venously placed chemotherapeutic agents to cross into the brain, to get therapeutically meaningful levels inside the brain, to kind of mop up or clean up cancer cells that are left behind in the way that's much practiced for other cancers. There have been attempts to place chemotherapy intracranially, and these have met with varying success. Radiation, on the other hand, can be employed either externally, and these are with the, I'm sure everyone here is familiar with the clinical linear accelerator, the large machines that live mostly in basements of medical centers that are used as patients move through. They aim a very high energy gamma irradiation at a patient from the outside. They're very carefully done. This is 99% of radiation oncology in this country. However, there are 3 key drawbacks to external beam radiation in this setting, in the recurrent brain cancer. Number 1, the time delay between the surgical removal of this cancer and the application of ionizing or therapeutic radiation. Secondly, the fact that the other brain structures will be dosed by radiation. The brain in general does not like ionizing radiation. It's protected considerably from it. And if areas of brain are dosed that are not intended to be in the therapeutic target, that creates problems. Thirdly, clinical linear accelerators are very large capital equipment. They require significant investment, maintenance, staffing, so they're geographically centered. So many people oftentimes cannot get access to external beam therapy, or they may not be able to conclude based on their logistical problems, such as employment. Internal radiation we call brachytherapy. These are the Greek roots of the words close and far. This being close, brachytherapy. You may have heard of it, something of a renaissance of brachytherapy, which was the original form of radiation therapy, by the way. In prostate cancer some years ago, brachytherapy became very in vogue again to treat localized prostate cancers. Brain brachytherapy has been attempted for the very reasons I imply, that it can be done quickly, it can be done with very large doses of radiation to a therapeutic target, very little to unintended adjacent tissues, which is highly desirable in the brain. However, it was fraught with a number of difficulties that have led to the fact that it's barely even practiced, brain brachytherapy, that is. The solution, we believe, and what we're trying to propose as a novel approach to radiation therapy, a novel technique, we simply don't know of anything like it, is this, and this is the gamma tile. What you're seeing here, and again, lacking a pointer, the strands you're seeing have individual sources with cesium-131 present in them. Cesium-131 is a radionuclide. It's an isotope. It's an X-ray emitter, very low energy. This is what you have to keep in mind, is that the radiation coming off of each of the seeds in here, and there's a little maybe more schematic illustration of the seeds inside the tile. The radiation emanating that's therapeutically meaningful is really just around that seed. It's just enough of a dose cloud to reach the dose cloud coming off the next seed. It's very low energy. We call these in the tens of kilo electron volts. These are not very energetic. Two ramifications to that fact. One is that spacing becomes critical. If one cannot space these sources approximately a centimeter from each other in both these dimensions you see, X and Y, delivering what we call uniform or homogeneous radiation becomes difficult. So the gamma tile solves this for us by holding these in place in a collagen tile. Now this collagen is actually a dural repair collagen, so it's been used, I think, over 1 million times inside the cranium to repair the dura mater at invasive craniotomy. And so using this as a carrier gets us something that's been used extensively inside the brain that takes these sources very nicely, spaces them apart perfectly well, and thirdly provides this third-dimensional Z axis offset that you can see represented at the top as the depth of the gamma tile. That spacing that takes the seeds off the brain's surface we think is highly clinically meaningful, and I'll try to show you why that is. Here's the placement of one of the tiles. The application of gamma tile takes about 3 minutes per the clinical studies to apply. The surgeon, once he's got or she has her or his target exposed and cleared out, the gamma tile is very quickly placed in there. The collagen becomes translucent once it's hit water there. So you can't see it, but it's in there, and we know it's in there because we can see the sources after the fact, and we can model the dose that's been delivered after the fact as well. And we, from experience, we know the spacing of these seeds, as I have explained in X, Y, and Z, as we think of it, maintains itself over the therapeutic life of these cesium-131 decay, the therapeutic lifetime of the cesium-131. Here's a representation of the radiation dose. Delivered by different modalities, as I explained earlier. With external beam radiation therapy, there's an impossible to avoid overdosing of areas that are not necessarily oncologic targets. So, as you'll see in the leftmost representation of conformal 3D external beam radiation therapy, which is external beam radiation therapy, you can see the target in the center where the green positive sign is. And these are also, that one's, no, those are markers, but you'll see the red radiation dose in the very center. The oncologist has drawn the target around the resection cavity. You'll see the red being very high. We're up into the, I can't read it for you, 7,000 or 8,000 rads, which is very, very, very intense radiation therapy. Now, the green and the blue, we're getting down into 4,000, 3,000 rads. That's 40 or 30 gray, which is that's near therapeutic radiation. That is intense radiation, and you can see. And again, these are areas, but you have to think of a volume of brain taking that dose that's completely uninvolved with the malignancy. So that is a side effect machine, frankly. And as much as there's been attempts to restrict that dose taken by uninvolved brain, it's impossible to avoid. But you see the gamma tile, we get this very, very compact dose that's very desirable. The gamma tile also begins right at the time of surgery. You can see the surgeon throw that gamma tile in there. And the problem is with external beam radiation delivery, there's a 3-week period required for recovery. During that time, regrowth of tumor can happen, does happen, as represented by that enhancing rim you can see around a resection bed within 3 weeks of surgery. There have been some trials done by physicians who were involved in developing this therapy at the Barrow, in the Barrow Neuroscience Institute in Phoenix, as well as some clinicians from the University of Arizona. Excuse me. Very quickly, number of histologies represented here. These are all recurrent cancers. Recurrent meningiomas, recurrent gliomas, high-grade gliomas, and recurrent brain metastasis. These are the representations. These are the probability density functions or Kaplan-Meier functions showing the risk of recurrence across these 3 histologies. All of these patients represented by the blue line show each one of those drops is a failure of a patient who has underwent surgery and radiation therapy, conventional external beam radiation therapy. The red line are the same patients who have been retreated. They've been re-put into the study. It's a very odd way of looking at a clinical trial, but in any event, you're looking at patients who had 100% local failure very quickly after standard of care therapy, who went into be salvaged with surgery plus gamma tile, and you can see in each instance these patients are faring much better with the gamma tile approach, even though we're in the recurrent setting with salvage therapy. Important side effects related to radiation therapy of the brain oftentimes center around what we call radiation necrosis. That is too much brain tissue getting too much radiation, leading to a necrotic event, which has to be excavated, acraniotomy, leading to a further operation. You can see the numbers favor the gamma tile approach over the reported numbers for both external beam and previous attempts at brachytherapy. We are convinced, and the clinicians are convinced, that this is due to, again, the array of seeds being very careful, spaced in both dimensions, as I showed earlier, to avoid hot spots where seeds are too close together, and also with the offset from the brain. We think it exposes the brain to really the perfect cloud of radiation, our target inside the brain, that just can't be achieved with any other method that anybody has developed to this point in time. In summary, we think gamma tile provides treatment option for patients without other options. As I explained, these are recurrent patients. Oftentimes, they've already taken enough radiation that they are no longer candidates for radiation that they may sorely need therapeutically. We believe we can show gamma tile reduces the rate of tumor recurrence, reduces complication rates, reduces need for reoperation, and keeping in mind that external beam radiation delivery is performed over a period of potentially weeks. This is a one-time application in the operating room. And based on the fact that we get the immediate delivery of radiation therapy conformally, right where it's needed in very high doses, with very little dose to other structures, we think that that's a further advantage to the approach. I hope I didn't cover that too quickly, but any questions?
Hi, I'm Linda Holtzman from Clarity Coding. Can you speak again to any other current forms of brachytherapy in the brain? I know that there have been liquid brachytherapy, and I saw in your background document that you said in the past people used to sow the radioactive seeds into the cavity. Is anybody doing any form of brain brachytherapy today?
Yes, and you're correct. There, between what we call interstitial placement of sources, That takes several different manifestations. That's all the way from taking miniature sources and really depositing them into a resection cavity. Some people put them into strands and kind of lace them around the resection cavity and kind of build their own implant, kind of like do it yourself. If you want to think of it that way, gamma tau being kind of a structured approach, the on-the-fly approach being a different way of looking at it. Those implants have been done and still are done. They've just achieved very little in the way of adoption because they take an awful long time in the operating room to put together in the brain. There's issues, operative time equals infection rates, and it's still impossible really to get those sources placed in that freehand fashion perfectly aligned and off of the brain. Liquid brachytherapy, just to finish answering your question, liquid brachytherapy was really considered to be the only way to get a uniform dose to the brain, but that required a temporary implant of a catheter, which was instilled with a radioactive solution, created a lot of problems that also prevented its adoption.
So if I understand you correctly, there are some cowboys out there who are doing physician-modified versions of brachytherapy in the brain right now. But generally speaking, there really isn't any other kind of brain brachytherapy going on today except for a handful of cowboys.
That's correct. So most all, and there have been other, I won't even dive into the history of this, but there have been lots and lots and lots of approaches because, again, this conceptual appeal of doing this is incredible. The question is, how do you do it right? So yes, many approaches have been abandoned. There's several, and we estimate less than 10 radiation oncologists out of about 4,000 in the U.S. are trying to cowboy this through, and that's been the status quo for probably the last 10 years at least, or so.
Thank you. Appreciate that.
Thank you. Operator, do we have any clinical questions from the phone lines?
All lines are unmuted.
Hearing none, then we will move to our coding options. If you'll turn in your handouts to page 28, and you will see that the current coding facilities can capture the use of cesium-131 collagen implants using existing code 3EOQ005, and that's introduction of other anti-neoplastic into cranial cavity and brain open approach. Option 1 would be to continue using this code. Option 2 would be to create a unique code to capture the use of cesium-131 collagen implants in adjuvant radiation therapy. We would create new qualifier 6, cesium-131, that you see on the table at the bottom of 28, in table 3EO of the administration section. We would use the existing fourth character body system, cranial cavity and brain, and the existing sixth character substance, anti-neoplastic, and we would add the new qualifier for the approach open. Option 3, which is found on page 29, would be create a new code in the X new technology section, and you'll see how we would add that into XOO, and you would see that we would add the brain open and then number 1 for the anti-neoplastic, and then 3 for the new technology group 3. CMS currently has recommendations for number 3 to put a new code in the new technology section. However, we would like to hear public comments on that. And in the meantime, you would continue to use the existing ICD-10 PCS code to capture this technology. So we'll take comments from the floor now.
Nellie Leon, she's saying, since Maddie opened up the door a little bit earlier, there is currently room in the 3EO table, the introduction, and that's where we have some of the other brachytherapy qualifiers. So my recommendation would be that so long as we have room and we can sort of group these things together, it would be easier to find if we would put it under what you have as option 2.
Thank you, Nellie.
Lynn Keene, Keene Consulting. I also agree that it should be option 2 because the way it's laid out, it seems like this would be a unique identifiable code even if the new technology add-on payment is approved. So, option 2.
Thank you very much. Any other comments from the floor?
I just had a question for the procedures. From the description, it's so invasive, so I'm a little confused why we classify under administration and introduction of the material. Do you actually implant this radium into the brain?
Yes. You were describing the approach to the surgery first.
Yes, so this is an open craniotomy. This is your traditional craniotomy. And yeah, following surgical incision of the tumor, the mass that the surgeon is after, these tiles are placed in permanently.
So would it be appropriate we have to assign additional craniotomy followed by administration?
Yes, you would code the procedure performed first, and then this would be an additional code to capture this procedure.
I would go with option 3 with these procedures.
Okay. Okay, operator, do we have any comments or questions from the phone lines?
All lines are unmuted.
This is Sue Bowman from AHEMA. I would support option 2 along with Nellie's and Lynn's comments. I think it would be good to keep this technology with other anti-neoplastic and brachytherapy substances that are included in Table 3E0.
Thank you, Sue. Any other phone line comments? Okay, we have another comment from the floor.
Linda Holtzman again. Another delayed reaction here. I like option 2 also. Since there is room, I think it makes sense to put it there because that's where I would look for it. My comment is actually something else, though, that I almost wonder if we should have either instead of cesium-131 collagen implant, or perhaps in addition to it, if we should add a value for, other brachytherapy source. I'm just a little concerned that by defining this so tightly as cesium-131 collagen implant, suppose they change their formula next year or something like that, that maybe we should have something a little broader. And if there are no other brain brachytherapy devices currently being used except for those 10 cowboys out there, maybe that would be sufficient to identify this. If it's the only thing being used on the market and we have a broader code, we could still identify it that way. And then if other types of brachytherapy come onto the scene, they could also use that code. And we wouldn't have to keep creating new values for, and I'm just making this up because I don't know anything about radiation, but suppose somebody comes out with a cesium-133 device, or, a fluoride 182 device. I can see continually having to add values. So maybe we'd be better here using a more generic one, which would be understood to represent cesium-131 since it's the only thing available at this time.
Thank you, Linda. And as the rest of you think about this, we would welcome any written comments on this suggestion also.
Nellie Leon, she's saying this is a follow-up clinical question, actually. Linda jogged my memory. Doctor, a few years ago, there was a proposal in the ICD-10 world which caused some problems once we moved to ICD-10 PCS, and this was for a gliadel wafer that was used sort of similar, where after the brain tumor was excised, this little wafer, anti-neoplastic wafer was put in. Is that still being done, or has that technology sort of gone away because there were challenges with it?
My understanding, it's still available.
Okay, and so so with that one, Linda, I think we were using the other anti-neoplastic. So would you call that brachytherapy in some way? Because thinking
No.
about your definition of brachy and what it means.
Yes, and I don't want to belabor this too much, but the mechanism of action of a chemotherapeutic wafer, where you're hoping that you've put enough of the agent in and that enough of that is picked up by the cancer cells to be toxic to the cancer cells. It's very different from applying radiation to a known volume at a known dose. And the mechanisms of actions are very different also.
So the other one was strictly chemo. There was no
Strictly chemotherapy,
radiation or any. Okay, thank you.
Well, thank you very much, and we look forward to your additional comments on this topic. We'll now ask Maddie Hugh to come up for the next couple of topics. And a reminder that we plan to break at 12:30 to 1:30 today, so we'll see how many more topics we can complete before 12:30.
We're now on page 30 of the handouts for occlusion of left atrial appendage. Currently, there's not a device value to identify occlusion of the left atrial appendage specifically with a clip in the ICD-10 PCS table 0 to L occlusion. This is not a new technology. And we have Dr. Whalen? No? On the phone? No? Is he on the phone? Okay. Okay, are either one of you going to come up? Okay, Michael Ferguson and Justin. Okay, I don't want to butcher your last name.
I usually start off by apologizing for my last name. I usually give Jones when I check into restaurants and other places, but like most things in life, I blame it on my ancestors and my genetics. So, with that, thanks everybody for having us here today to CMS and the coordinators for the meeting. So, let me get my clicker. So we're going to try and cover a lot of ground relatively quickly, including an overview of the current landscape, the various methods for surgically managing the left atrial appendage, the devices and techniques that are used in surgically managing the appendage, as well as going over briefly the changes requested in the application and the associated clinical rationale. All right. So, in discussing surgical management of the left atrial appendage, you really have to talk about why the appendage is being managed in the first place. The left atrial appendage plays a very important role in management and treatment of patients that present with atrial fibrillation. Atrial fibrillation, for those that don't know, is the most common form of cardiac arrhythmia. Patients with AFib are at 500% higher risk of having a stroke. And this is because when the heart fibrillates, blood does not efficiently enter and eject from the heart, causing it to pool potentially, and when blood pools, it clots. In patients that do have AFib, it's been shown that 90% of strokes in patients that do present with AFib originate from within the left atrial appendage. And this appendage is a small muscular pouch that's attached to the left atrium that has a hollow interior. So when blood is not, again, efficiently entering and ejecting from the heart, blood can pool inside of that small muscular pouch. In cardiac surgery, surgeons will routinely manage the appendage through various means, and we're going to talk about that on the next slide. Surgical left atrial appendage management is performed in the most common forms of cardiac surgery, including coronary artery bypass grafting, mitral valve repair and replacement, and aortic valve repair or replacement. And then most recently, in January of 2017, the Society of Thoracic Surgeons, which is the largest cardiothoracic surgical society in North America, released some clinical guidelines which recommend management of the left atrial appendage. So there are various techniques for surgically managing the appendage, and these techniques do contrast with other means of managing the appendage, which people might have heard of, including through percutaneous access or device delivery, which is using an endocardial catheter to plug the appendage from the inside of the heart. All of the techniques shown here and that we're talking about today are applied epicardially or outside of the heart. So these techniques include suture ligation, which involves stitching the appendage closed using common sutures or an endoloop, stapling the appendage using a surgical stapler, excision of the appendage, which involves cutting the appendage off entirely and sewing the opening in the atrium created by the excision back together, and then finally using an AtriClip exclusion device, which we're going to talk about in a bit more detail. So the AtriClip device is marketed in the United States for occlusion of the appendage in conjunction with other open cardiac surgical procedures. This is a unique indication compared with other epicardial devices or techniques. There's no other indication like it. When we pursued clearance for the device originally in 2010, the study that was executed showed excellent safety and closure efficacy for the device, and there's a reference in the back of the presentation to that study. And that has held true since the initial launch of the first generation of the device. Since that time, there have been several studies that have demonstrated that inadequate closure using other methods can increase risk to the patient significantly, and we'll talk about that a little bit more. Utilizing an AtriClip in cardiac surgery is very common. So to date, there's been over 95,000 clips that have been deployed. Actually, this data is, in this presentation is a couple of months old, so we're up over 95,000. And the important distinction of a clip versus some of the other techniques is that the appendage is entirely eliminated within a 90-day period. So the appendage ceases to exist, and I'll explain how this works on a couple of slides. So the clip itself is comprised of a rigid titanium core which provides structural stability, an outer urethane extrusion to promote distributed clamping pressure along the entire length of the device, a 90-degree design which minimizes contact with surrounding tissues so that the circle ends of the device don't come in contact with other tissue, and a nitinol spring which provides parallel clamping closure along the entire length of the device, and a knit polyester cover which promotes tissue ingrowth after the device is implanted. So these materials are commonly used in other medical devices, some examples of which are shown in the slide, including stents, leads, patches, grafts, and valve rings. This picture here is a three-dimensional CT scan of a preoperative image on the left, on which you can see the appendage, which is outlined in white. On the right is a postoperative image of the same heart after a clip has been deployed. You can actually see the outline of the clip also in white. What you can see also here, and the important distinction, is that the appendage is no longer visible because it does not exist. It has grown in on itself. Once you place the clip, it applies constant pressure, and the appendage itself becomes necrotic, and the tissue no longer is there. It grows in on itself. So if this picture was shown using some of the other techniques, because the appendage is not necessarily destroyed, it would still potentially show up on this picture, meaning that the opportunity for reconnection or recanalization to the appendage still exists. And there have been a bunch of studies published on the clinical efficacy of using the AtriClip, one of which in particular is included in the references in the back of the presentation. So here we're going to outline our primary rationale for the proposed changes. Number one, the change would allow for more precision in tracking these different approaches and methods to treat the left atrial appendage surgically. And distinction between these techniques is important, and today under the current coding, they are indistinguishable. Clinically, secondly, it's important to distinguish between these methods so that postoperative or long-term care options can be analyzed. For example, decisions about whether or not to anticoagulate a patient postoperatively, those decisions might be different if a surgeon or a cardiologist or other clinician knew what kind of technique was actually deployed, or if there was a risk for inadequate closure using other techniques. And then thirdly, these changes would allow for a more effective way to study value amongst these different techniques for managing the appendage, so that value could be established for CMS beneficiaries on a retrospective basis or on a prospective basis. And with this change, the impact of different techniques can ultimately allow for more discrete procedural and cost data that would be of benefit for CMS beneficiaries. Thank you very much.
Do we have any clinical questions?
You've probably heard that I'm Linda Holtzman. Yeah.
Yes.
I'm not clear. What are the other types of extraluminal devices that will go around the atrial appendage, in addition to the AtriClip, which I certainly know of?
Epicardially, I'm not aware of any others. I mean, the other techniques, as I described, are sutures or surgical staplers. So those are the I can go back.
Please, thank you.
Yep. So these are the techniques that are used to epicardially manage the appendage. So the only device that I'm aware of is the AtriClip. There's really nothing else like it.
Okay. Thank you.
Yep. Any other questions? Okay. Yeah.
Moderator, can you open the phone lines? Are there any clinical questions?
All lines are unmuted.
Okay, well, do we have another comment from the floor? No? Okay. We'll go ahead and review the coding options. At the bottom of page 30, we'll see currently occlusion of the left atrial appendage with a clip would be coded to table 02L, occlusion of heart and great vessels with the body part value left atrium and the device value extraluminal device. And we have the qualifier value for left atrial appendage. Coding option 1 would be to continue to use that code. Option 2 would be to create a new device value for extraluminal device clip in the table 02L for occlusion of heart and great vessels. And you can see the table. And we don't have a recommendation. We'd like to hear comments from the audience regarding the need or benefits for having a specific device value with the clip.
Okay, you might have noticed a flurry of activity on this side.
Yes.
And I think it's because we're a bit confused based
Thank
on...
you for calling Brooks.
We're a bit confused because we already have a device value that says extraluminal device, and it sounded like there was nothing else being used as an extraluminal device in the left atrial appendage. So can you clarify that? Because based on that, Doctor, that last slide that you had sutures, which we would not consider extraluminal device. You had ligation, and you had staples, and we wouldn't call any of those extraluminal devices. So can you clarify what you're looking for here?
Yeah, I think there have been other devices that have been marketed previously. And again, I'm not an expert in exactly whether or not a stapler or staples that are permanently implanted in the body would constitute a device, but there have been other stapler-like devices that have been previously marketed for epicardial closure of the appendage, and I believe there's actually a reference to one of those devices in the ICD-10 coding book. So there are, just to clarify what my comments, there's no device like the AtriClip in particular, but my understanding is that there have been other devices that have been coded in this particular case.
But the other devices are extraluminal devices, and you're not talking about staples or ligation.
Again, I don't know what classification exactly some of those other devices would technically fall under, but hopefully I'm answering your question, maybe not, but.
Sorry, go ahead.
That's okay. Lynn Keen Consulting. It really does seem like the device value that we have, CE extraluminal device, would be the device that we would select, and that the current coding would be correct. Just through some quick research and discussion, it just seems like there aren't other options that we would put into that device value so that it would correctly describe this device.
Thank you, Lynn.
I'm still Linda Holtzman. I just want to follow on with Nellie and Lynn. I don't see a reason to do this. I understand that you're talking about, or I assume you're talking about the Tiger Paw, but as far as I know, that's not on the market anymore. So the only thing that's currently an extraluminal device is, in fact, your clip. So you could identify it easily because it's the only one that's going to be using value C, current value C. And to be honest, even if Tiger Pole was still on the market, I don't know that that it's consistent with the fundamental principles of ICD-10 to make this kind of differentiation. An intraluminal device can be lots of different things. You know, it can be a stent, and it can be a graft. I mean, there's lots of different things it can be, and we're all getting used to the notion that we have to read the codes very closely to identify what those items are. So I'm not sure this would set a good precedent to deviate from that specific ICD-10 principle. There are times when you need to do it, like for an NTAP, but this isn't an NTAP. So I can't say I'm keen on getting behind this. So nothing personal.
Thanks, Linda. He said none taken. Okay, do we have any other comments from the audience? Operator, can you open up the phone lines, see if there's any additional comments?
All lines are unmuted.
This is Sue Bowman from AHEMA, and I would just agree with the previous comments. I, too, don't see a reason for this distinct code because I think the current codes and values are going to capture this device.
Thank you, Sue. Okay, so it sounds like there is generally not support for option 2, and everybody agrees that the current code is satisfactory. Okay, all right. Thank you very much. Okay, we need to deviate a little bit from the agenda, and I'm going to have Michelle Joshua come.
Okay. As Maddie stated, we are going to deviate slightly on the agenda, so we will be moving on to the administration of Vyxeos. Here to present for the clinical presentation is Dr. Margaret Tumas. And the current issue with Vyxeos is that we currently don't have a code in ICD-10 to describe the administration of Vyxeos or cytarabine and daunorubicin liposome for injection. This is a new technology application, and it is pending FDA approval. Here to present is Dr. Margaret Tumas. Welcome. Thank you.
Thank you for flexing the schedule for us today. Good afternoon. My name is Margaret Tumas. I'm here representing Celator Pharmaceuticals, which is a subsidiary of Jazz Pharmaceuticals, and our request for a new ICD-10 code for the administration of Vyxeos liposome for injection. The request for a new technology add-on payment and an ICD-10 code is being made. An NTAP application for Vyxeos liposome for injection is currently under review by CMS for fiscal year 2018 effective date. An ICD-10 code is necessary to identify the intravenous administration of Vyxeos in the inpatient hospital setting. Vyxeos is the proposed trade name that's been conditionally approved by the FDA. It's also known as CPX 351 and referenced throughout the clinical literature. A rolling submission for Vyxeos was initiated in September of 2016, and the FDA has provided regulatory designations as breakthrough therapy, a fast track designation, and orphan drug designation for this molecule. Vyxeos, if approved by the FDA, will represent the only new drug to treat acute myeloid leukemia in more than 40 years. The proposed population for this treatment, this drug treatment, will be adults with acute myeloid leukemia. The specifically designed novel Combiplex technology platform enables a synergistic 5-to-1 molar ratio of two drugs, cytarabine and daunorubicin, which are encapsulated within a nanoscale liposome delivered directly to the bone marrow and preferentially taken up by leukemia cells. Today, the standard of care for treatment of AML or acute myeloid leukemia is induction using two separate drugs, free drug dosing, sometimes known as 7+3. Cytarabine is given continuously by IV infusion for 7 days, and daunorubicin or an anthracycline is administered intravenously on 3 days. Again, no new drugs have been approved in 40 years. VYXEOS will meet a clinically significant unmet need. Acute myeloid leukemia, as you might know, is a very serious and life-threatening condition, and there's two major prognostic factors which impact the outcome of these patients. One is age, and the other is the chromosome status of the patient. Older adults with acute myeloid leukemia, when compared to younger patients with the same disease, have a much poorer prognosis. They represent a discrete population in terms of the disease biology. They have different treatment-related complications, and they have different outcomes. As a consequence, up to 50 to 60% of elderly patients actually do not get treated following diagnosis with AML. The table here just represents the different outcomes by age group. You'll see that patients less than 55 have substantially better outcomes, specifically in survival of 18 months, median survival, and in a patient that's greater than 75 years, a median survival of 3.5 months. So as patients age, the outcomes are worse. Preclinical studies with VYXEOS have demonstrated this unique and distinct mechanism of action of this new molecule. The proprietary and novel Combiplex ratiometric dosing technology platform addresses some fundamental shortcomings of the free drug dosing, and it increases the efficacy of these two drugs by fixing them and controlling a 5-to-1 drug-to-drug ratio encapsulated within a nanoscale liposome. The Combiplex technology delivers this 5-to-1 molar ratio of these two drugs to the bone marrow, where the VYXEOS is preferentially taken up by leukemic cells. This sustained drug ratio of cytarabine and daunorubicin can't be achieved with conventional forms of dosing, no matter how it's given, dosing or schedule. And clinical studies that I'll talk about next provide the evidence that confirm that this is a distinct mechanism of action of VYXEOS, which is a novel single anti-cancer treatment for acute myeloid leukemia. In a randomized controlled trial comparing VYXEOS to free drug dosing, superior overall survival was seen in the VYXEOS treated arm. This graph shows a difference in survival between patients on VYXEOS versus those with 7+3 free drug dosing, and in a pre-specified subgroup analysis of patients aged 60 to 69 and also in patients aged 70 to 75, demonstrated that their survival benefit was even appreciated within the older age group. And as you recall from the last table that I showed, we do have a progression of poorer survival in the oldest age group. In addition to this benefit in overall survival, there was a virtually equal adverse event rate between the two groups, the VYXEOS compared to the free drug dosing. So we have a survival benefit, yet adverse events are the same. In addition to the survival benefit, we also saw a statistically significant difference in the response rates between VYXEOS and free drug dosing. The response rate indicates the proportion of patients that can go on to be considered for transplant, and transplant is ultimately the cure that you're looking for, or is the only way to get to a cure with acute myeloid leukemia. VYXEOS patients were more likely to be considered appropriate transplants patients. In addition to these two primary outcomes, other substantial clinical improvements were noted in this randomized controlled study where VYXEOS was compared to free drug dosing, include the fact that there is maybe a lower risk of early death. And in fact, the 60-day mortality of the VYXEOS treated patients was less than that of the free drug dose patients, and less of the patients died from progression of their disease. In addition, VYXEOS may provide a bridge to transplant with better outcomes after transplant, and in a post hoc exploratory analysis, patient outcome following transplant strongly favored patients in the VYXEOS arm with fewer deaths within 100 days of transplant and substantially longer survival after transplant. In another randomized trial, a phase 2 study, VYXEOS was actually studied compared to standard of care in a younger patient age group, and higher response rates with acceptable safety in poor risk first relapse patients was also noted. The proposed dosing and administration of Vyxeos is as follows. Vyxeos will be supplied in 50 milliliter single-use vials, with each vial containing Vyxeos with cytarabine 100 milligrams and daunorubicin 44 milligrams contained within the liposome. And the patient dosing is determined by the patient's body surface area. All patients will receive their induction therapy as an inpatient, and in the clinical trials, 50% of the patients also receive consolidation therapy in the inpatient setting. In summary, Vyxeos represents a substantial clinical improvement for acute myeloid leukemia patients, and through the novel CombiPlex technology, Vyxeos is the first and the only anti-cancer agent with preclinical data showing that it delivers and maintains a fixed synergistic 5-to-1 molar ratio of cytarabine and daunorubicin to cancer cells in a nanoscale delivery complex. And if approved by the FDA, the Vyxeos will represent the only new treatment for AML patients to improve survival since cytarabine and daunorubicin were approved over 40 years ago. A randomized controlled trial in high-risk patients with acute myeloid leukemia demonstrated substantial clinical improvements for Vyxeos compared to free drug dosing. There's superior survival with an acceptable safety profile. There may be a lower risk of early death. There's a statistically significant response rate, and Vyxeos may provide a bridge to allogeneic transplant for this poor-risk subgroup of AML patients. Thank you. Any questions?
Operator, do we have any questions on the line?
All lines have been unmuted.
Noting that we have no questions in the auditorium nor on the telephone line, we will proceed with our coding options. Currently, Vyxeos can be coded with the current code from Table 3E0, introduction of other antineoplastic into peripheral vein or into central vein. We have two coding options. One would be not to create a new code and to continue using the current coding option from Table 3E0. The other, option 2, would be to create new codes in Section X, new technology, to identify the administration of Vyxeos. CMS is recommending option 2 at this time, create new codes in Section X, new technology, to identify the administration of Vyxeos. Interim coding advice would be to continue to report the intravenous infusion of Vyxeos as described using the current coding options. Do we have questions in the audience or on the telephone line regarding the coding options for Vyxeos? Okay. We note that we have no additional questions. We thank Dr. Toomas for her presentation. Thank you. Absolutely. Okay. Okay. Our next presentation will be that of Dr. Elizabeth Faust for the administration of KTEC-19, axicabtagene ciloleucel, and the current issue is that we currently do not have a unique ICD-10 PCS code to describe the administration of KTEC-19 or axicabtagene ciloleucel. This drug is not yet fully FDA approved, and this is a new technology application. Here to present a clinical presentation for KTEC-19 is Dr. Elizabeth Faust. Welcome.
Thank you for the opportunity to speak to this group. I'm Elizabeth Faust, Vice President of Medical Affairs at Kite Pharma. And what I want to talk to you about today is the request for the ICD-10 PCS code in support of our NTAP application for KTEC-19. The proposed indication for this new therapy would be the treatment of adult patients with relapsed refractory aggressive B-cell non-Hodgkin's lymphoma who are ineligible for an autologous stem cell transplant. If approved, this would be the first and only treatment for these patients. This would be the first engineered autologous cellular immunotherapy comprised of chimeric antigen receptor, or CAR T cells, that recognize CD19 expression on cancer cells as well as B cells, and which has demonstrated efficacy in chemorefractory aggressive B cell non-Hodgkin's lymphoma and a multi-center clinical trial. This product candidate has breakthrough therapy designation as well as orphan drug designation. We'll be calling it KTE-C19. The technology name is axicaptogene silolysyl, but we'll call it KTE-C19. We initiated a rolling submission at the end of last year for KTE-C19. So KTE-C19 will meet a substantial unmet medical need for patients with aggressive B-cell non-Hodgkin's lymphoma. The most common subtype of NHL is diffuse large B-cell lymphoma, or DLBCL. So most patients are initially treated with chemotherapy, R-CHOP, in the first line. Unfortunately, some of these patients never respond and therefore are designated chemorefractory diffuse large B-cell lymphoma patients. That's the purple bar at the bottom. Some of those patients do respond, go on to relapse, and receive additional lines of chemotherapy. Unfortunately, many of those also do not respond. And then some of those patients do have a response and are able to go to an autologous stem cell transplant. Those patients who relapse from their transplant within a year are also designated chemorefractory diffuse large B-cell lymphoma. So most patients who fail R-CHOP will ultimately die of their disease. SCHOLAR-1 is a study that confirms this very poor outcome in these chemorefractory diffuse large B-cell patients. SCHOLAR-1 is the first patient-level retrospective meta-analysis in patients with chemorefractory diffuse large B-cell lymphoma. So in this large study of 635 patients, you can see in the table that only 26% of these patients had a response, and only 8 of those were able to achieve a complete response or a complete remission of their lymphoma. If you look at the graph on the right-hand side, you can see those 3 different categories of chemorefractory that we were seeing in the last slide with the arrows, all did equally poorly. And if you look closely at that graph, what you see is at about between 6 and 7 months, half of the patients have died. So if approved, KTE-C19 would be the first engineered autologous CAR T-cell immunotherapy for aggressive B-cell lymphoma. It has a very unique mechanism of action that is depicted in the cartoons here. So what we do is we take a vector that has the CD19 gene that is in a retrovirus, and the retrovirus infects the target cell, in this case a T cell. And what it does then is reprogram that T cell to attack and kill cells expressing CD19, including tumor cells, and that's what you see on the right-hand side here. This vector was developed in collaboration with the NCI, and we'll look at some data from some Kite-sponsored trials and some studies that we did in collaboration with the NCI. This schema is showing you the engineering and manufacturing process for KTE-C19, so we'll walk through this step by step. So the patient's white blood cells or T cells are collected through a process of apheresis, or more specifically, leukapheresis. That material is packaged cold and sent to Southern California, where we isolate the T cells and activate them. And then they're engineered with the retrovirus that we saw in the previous slide to introduce the CAR gene. Those cells are then expanded and then they're frozen. And that frozen bag is then sent back to the sites to be infused into the patient. From the apheresis to sending the cells back to the site takes about 2 weeks. The clinical program for KTE-C19 is depicted here. So the first study, Zuma-1, Zuma because of a beach in Malibu, was a pivotal phase 1-2 multi-center open-label single-arm trial in aggressive refractory non-Hodgkin's lymphoma in patients with this chemorefractory disease. It's a really similar population as what was studied in Scholar 1 that we looked at before. And in Scholar 1, of course, patients received the standard of care. And we saw there that the outcomes for those patients are very, very poor. And this is why the Zuma 1 was not a randomized or placebo-controlled trial, as that was not possible. The one thing I'd like to point out here with Zuma 1 is just the age population does fall within the Medicare population. Zuma 2 was a study that was done, Study 2 is an NCI trial that was done in collaboration with the NCI, similar patient population and similar age range of patients. Now let's look at some of the data. So the bottom line is that there was substantial improvement in overall response rates for KTEC19 compared with the standard of care as we saw in Scholar 1. So if you look at the table, that blue box, what you can see is 79% of patients had a clinical benefit, that is, had a response. And this response was consistent over all the refractory subgroups that we looked at and also across age groups. The other trials, the phase 1 part of Study 1 and Study 2 also have very similar outcomes. And this in contrast to Scholar 1, which was only 26% response. So 26% to 79% was quite an improvement. If we look at those patients that had a complete response or a complete remission of their lymphoma, what we see is that in the Zuma 1 trial, 52% of the patients actually did achieve a complete response. Once again, this was across all the refractory subgroups, was very consistent, and also across all the age groups that we looked at. And then if we look at the other two studies that we're talking about here, in Study 1, we had a 57% complete remission rate, and that follow-up is still being reported, similar across Study 2, the NCI trial. And again, in stark contrast to the 8% that was seen in Scholar 1 with the standard of care. These responses are durable. So in the phase 2, we see that there 40% have ongoing complete remission at the 3-month time point that's depicted here. In Study 1, the phase 1, of course, the phase 1 was started earlier, very similar CR rates of 43%, and those are ongoing at month 12. And then in the NCI Study 2, again, very similar response rate at 47%, and some of those are ongoing out to 20 plus months. And again, in stark contrast to the 8% CR rate that was seen with the standard of care in Scholar, and a median overall survival for those patients of only 6.6 months. Turning to safety, there is a positive risk-benefit profile for KTEC19 and a very manageable toxicity profile. Most of the patients in the trial did experience a grade 3 or higher adverse event, which was not a surprise. These were managed according to standard of care. The KTEC19 related toxicities are self-limiting and generally reversible. Grade 3 or higher cytokine release syndrome was seen in 18% of patients with a median time of resolution of 9 days. And grade 3 or higher neurologic events were seen in 34% of patients with a median time of resolution of 18 days. We saw no cases of cerebral edema in any of these studies. There's no clinically important difference in adverse events across age groups, including the cytokine release syndrome and neurotoxicity. And by the time of cutoff, there were 2 subjects, or 3% of the patients, had died due to the KTEC19 related events. This is, we're going to look at the dosing and administration in a little bit more detail here. So as we saw before, the patients are leukapheresed in an outpatient setting. That product is sent cold to California where the processing happens. The patients also receive in an outpatient setting conditioning chemotherapy starting on about 5 days before they get their cells. They're then checked into the hospital for their KTEC19 infusion. The infusion is a single bag, and everything in the bag is infused. So it's a one-time treatment. The patients are hospitalized per their physician's wishes, and then after that monitored in an outpatient setting. We do the first tumor assessments at 30 days post that single infusion. So in summary, these interim clinical study results demonstrate that KTEC19 represents a substantial clinical improvement. This would be the only therapy for these patients, these relapsed refractory aggressive B-cell non-Hodgkin's lymphoma patients who cannot receive a stem cell transplant. There's no curative options for these patients. We saw substantial improvements in overall response rate. We saw substantial improvements in CR rates, complete response rates, and those rates were durable. All of those results were very consistent across refractory subgroups, across ages, and across the studies that we looked at. KTEC19 will provide a meaningful advantage over standard of care, and it is a very important advancement for the treatment of aggressive non-Hodgkin's lymphoma. Thank you. And we'll take questions.
Perhaps I missed this earlier, but is the brand name that is going to be used, is that KTEC19?
No, we don't have a brand name
You
yet.
don't have one
No.
yet. Okay,
Yeah.
that's what I thought.
Yeah.
Okay, so when do you expect to have a brand name? And the reason why I ask this is that typically the way it would be documented in the record perhaps would be the brand name, and it'd be important to have it in the substance key so that people can sort of relate that, because they're not going to see if they're not going to see KTEC19, and they're not necessarily going to see the full name. So something will need to be there for the coders to sort of match it up and know what this is.
And we are planning to do a supplement as well, so that'll be included. Yeah.
Okay, do you know more or less when you might have a name, since it looks like you're applying for fiscal year 2018?
That's right, yeah. I don't know exactly when we're going to have the name.
Okay, maybe you could follow up
Yeah,
with
we can.
CMS then once you know that, so they can make sure they get all the right names.
Yeah.
If the code goes through. Thank you.
Hi, I'm Laurie Johnson from Panacea Healthcare Solutions. My question is that this is an infusion, correct? And the patient is in the hospital one day?
So the protocol stipulated the patients were hospitalized for 7 days. They could stay longer than that. It just depended on what the physician wanted.
Okay.
Questions on the line. Operator, will you open the lines for questions?
All lines have been opened.
Do we have any questions on the telephone line? Okay, noting that we have no additional questions, we will move into the coding options. Current coding for KTEC19 currently include using options from Table 3E0, Introduction of Other Anti-Neoplastic into Peripheral and Central Vein Percutaneous Approach. We have two coding options. The first would be to continue to use codes from Table 3E0 and not create additional new codes. The second option would be to create a new code in Section X, New Technology for KTEC19, as depicted on page 41 in the chart or table. CMS recommends option 2, creating new codes in Section X, New Technology, to capture the administration of KTEC19. Interim coding advice would be to continue to use the current code in Table 3E0 for introduction of other anti-neoplastic into peripheral vein or central vein for KTEC19. Do we have any questions in the auditorium or on the line for coding options for KTEC19 at this time? Okay. I note that we don't have questions, and so we thank Dr. Foss for her presentation. Are we moving on to the next subject, or are we breaking? Okay. And here's Pat Brooks.
We will now take a lunch break, and we will reconvene at 1:30. And hopefully, those of you who haven't been here before know that you go down one level. There's an auditorium there, a cafeteria. So we'll see you back at 1:30.